Folks, thanks for coming on the line with us today. My name is John Dubas with Premier Marketing, and we'll be spending the foreseeable future here, the next hour or two, going through veteran training, dealing with different programs that affect those who have served our country with veteran health care. We want to make certain that we get you all the information you need to maximize your selling potential, but also best serve the community that we share as part of what we're looking to do to improve lives through our experience as insurance agents. We have Darren Davis with Humana on the line with us today, and Darren is graciously going to go through the training that you see on your screen. And at this point in time, I'll mute myself after telling you that any questions that you have, please put them in the questions box or the chat box, and they will be sent out as part of the follow-up to today's presentation, so everyone will benefit from the questions that are being posed. That'll come to you, the follow-up will come to you within a day of the presentation, so watch for that to come from us. And with that, I will fulfill my promise, mute myself, and turn it over to Darren. Thanks, Darren.
Thanks, John. Hope everybody's having a great week. I'm looking here, and it looks like we've got a few attendees on here. So thanks so much for having me. Give you a little bit of background on myself, and I'll go ahead and go to my next slide so you've got my name in front of you. I am Darren Davis. My contact information is up here on the screen. Feel free to email me directly if you have any questions, or of course push that through John. But give you a little bit of background. I started with Humana about 10 years ago in field sales. So I've done what you all do. I've sat across that kitchen table and done the seminars and done the marketing events. I've done all those things. Did that for a few years with Humana, and then I spent about 6 years with Humana as a market manager. So I did that here in Arkansas. I'm based out of Little Rock, and I actually am working from home typically. I do travel a lot, so when I'm here, I work from my house. So I don't have any animals, but you may hear a siren or some crazy person knocking on my door. So those are always fun things that happen when you work from home. So I did want to show you this slide real quick. Make sure you had my contact information. The email address you see at the top, veteranschannel@humana.com, is kind of a catch-all email for us. So really any questions you have, first of all, we always encourage you to go through your upline, send your questions to Premier, because a lot of times they already have the answer. But in the event that you can't do that or you choose not to, you can always send those to veteranschannel@humana.com, and we'll do our best to kind of triage those questions and answer them to the best of our ability. So you can always send things to me directly, but if I'm traveling or if I will be out for about a month later this summer with the National Guard. So I do still currently serve in a Guard unit here. So I'll be gone for a month. So obviously I'm not going to respond to that email for a while. So that's a good place that if I can't get to it, somebody else will. So my boss is Ed Sandrick. He's the director of our channel here. And then typically when we're fully staffed, we have about 4 veteran executives here at Humana, and our job is really twofold. Number one, it's to provide training like this to you all, to not only field sales, but telesales agents, to some of our internal operations people, some of our Humana at home nurses, you name it, anybody that really wants to understand Humana's role in the veteran space, and how we work with, how our Medicare business works with Tricare, VA, ChampVA, those things. That's really my primary role. Number 2 is we manage a lot of relationships, and I'll talk about them here shortly. I manage a lot of our relationships with the VFW, both nationally, state, locally, the VFW, AMVETS, and really any other veteran organization that we come across, which is always going to change. You know, in Texas, we may do a lot of work with the American Legion. In Nevada, we may do a lot with US Vets, so on and so forth. So those are kind of our two primary roles. So I have all of Texas, and then really what we call the Western region. So I kind of have Texas and almost everything west of that, really up through like Oregon and Washington. Miss D. Hughes down here is a Gold Star mother with Humana. She's kind of come from the same background I have. Gold Star mother, Marine mom, Army wife, and she runs Florida for us. And then we just lost Mark, and Mike. They're still with the company. They just took different roles. So we're actively trying to find some qualified candidates to fill those roles. So until then, I am your myself, or D would be your primary contacts here at Humana for all things veteran. We are on Facebook, so if you do have your phone or your Facebook app up, you can go and type into your search field Veterans Wellbeing Community, and you'll be able to follow the Humana Veterans channel there. So if we ever have any updates to Tricare benefits, anything with VA, any news in that space, ChampVA, anything along those lines, we try to post those updates there for you so you can see them pretty quickly. But besides that, you'll also see a lot of content from a lot of the events we go to. So we are a VFW national sponsor. So you'll see content from our national convention with them, state conventions. You'll also see things from Rolling Thunder, which is a huge veteran bike rally up in DC that we've sponsored for the last couple of years. So you'll see a lot of things like that. But you'll also see us cover events locally. So, if you're an agent in Dallas, or if you're an agent in Denver, we may do a small stand down with the VA, or Humana may host a Vietnam veterans pinning ceremony. So you'll see content from there. So it's kind of a fun page to follow. I do want to give a quick background before we jump into it. And by the way, today's training, my goal is really, I think what's been missed in this training with either other carriers or even us in the past is we've done a great job at providing the information, but we don't always give you the tools to really apply that at the kitchen table. So the scenario being, you have somebody who says, hey, I've got the VA, I don't need Medicare. How do you combat that? What are some things you can do to really educate that person and show them that they do need what you have, what you're offering? So that's really what we're going to dive into mostly today. But before we get there, I want to give you a quick background. So everybody knows we're a Medicare company, obviously, but we also hold a Tricare contract as well. We used to hold two, and we didn't really lose one of those contracts. They just kind of combined them into one giant contract. So Humana is actually responsible for around 6 million Tricare members across the country. So we really kind of have the South region and the East region, not out West very much. There's another company that holds that contract, but we have the majority of the country. And we have since 1996. So that's not a new thing for us. It's been part of our DNA for a very, very long time. So a lot of veterans do know our name from Tricare and or Medicare. We are the national sponsor for the VFW. There's a few shots from our national convention. We've been their exclusive Medicare Advantage prescription drug provider since 2012. We recently added MedSup to that suite of products, and we also recently signed a new contract with them to go through 2023. And that's significant. The only reason I mention that is that's very significant to me because they're such a large organization, well-respected organization in the veterans world. And they could have chosen anybody to represent them. And they obviously have lots of carriers knocking on their door, and they chose Humana back in 2012, and then they chose us again just recently. So we have a really good relationship with them, and we're very, very proud of that. Another quick backstory, back in 2011, Humana committed to hiring at least 1,000 veterans and or their spouses by the end of 2013. And we really kind of blew right through that goal. This slide is actually a little bit old because it says 3,400 vets and spouses hired, and we're actually over 4,000. So very, very proud of that. Makes up 8-9% of our workforce, and we're hoping to get to 10% soon. Me personally, my brother is an Afghanistan combat vet, and we've hired him twice. So we hired him once to go to work for a company that we owned, and then that company ended up shutting their doors in his area and laid him off. And then now he's a field sales agent with us, a career agent. So we actually hired him twice. So something that we're doing to not only put vets back to work, but we want veterans working for us. We think they make great employees. We've all the veteran focused talent site you see in front of you, or that last bullet there. I know I don't have the link up here. It's a kind of a long, drawn out link. I'm actually going to send to John and Michelle, I'm going to send them a cheat sheet. So I'm going to be going over a lot of links, phone numbers, websites, things like that today. If you're not taking notes or anything like that, or if you're in the car and you're just kind of listening in, we are going to send a cheat sheet out to you that has all those things on it. So when I talk about this veteran-focused talent site where you can send veterans to it to apply to either work for Humana or work with one of our partner companies, hey, don't worry, we're going to get you that link. It's going to be on that cheat sheet. As a company, we've also collected around 30 tons of clothing, sleeping bags, blankets, hats, coats, shoes, you name it, to push out to homeless veterans or veterans in need. So we've done what we call stand downs across the country. And really a stand down is just a way that the community pools all their resources for homeless veterans or veterans in need. So you see a lot of VAs do these things. You see a lot of VFWs and American Legions put on stand downs. So Humana gets involved in those pretty regularly. We've also had a couple of corporate-wide initiatives to collect DVDs and Easter baskets to send to our deployed men and women overseas. So again, just something we're very proud of. This is something we've been doing for, like I said, the past 20 years. We've had the Tricare contract, but then a lot of our other initiatives with the veteran community we've had for 5, 6, 7 years. I always kind of joke and say Humana was doing it before it was cool. There's a lot of carriers that are doing veterans things now. They have veterans programs, and by the way, that's a good thing. Anytime people are jumping in to help veterans, I don't care if we're competitors or not. That's positive. We like that. But we do brag and say we've been doing it for quite a while. So this is something we're just trying to raise awareness for. Food insecurity is kind of rampant among veterans. So if you talk to a VFW or a VA hospital somewhere, a lot of times they will tell you we don't need clothing donations. Like we people send us all their old clothes. We're bursting at the seams at our closet. Like we don't need any more. The big issue with our military households is food insecurity, and food insecurity simply means somebody can't afford to feed their family, or they don't have access to healthy food. And so it affects 20% of military households, which is a kind of an alarming statistic. And that's not just your 65-year-old Vietnam veteran. That's also your active duty, 30-year-old E5 in the Army, family of 4 can't afford to feed their family. So this is something we're trying to raise awareness to. We're partnering with Feeding America to conduct food drives all over the country. So you'll kind of look for that coming to a theater near you. You'll see us do a lot of things with the VFW in the near future. We're kicking off the VFW convention this year with the national convention with a large food drive. So that's what we'll be doing. Really quickly, we just signed this is a few months old, but we signed up as a partner with the Vietnam War Commemoration. And so these are ceremonies. This is a DoD program that's designed to welcome home every Vietnam veteran that's alive today. And if you're a student of history, or if you've been around long enough, you may know that we did not treat our Vietnam veterans very well when they came home. We kind of pushed them in the corner and said, we don't want to deal with you as a country, and did not welcome them home. So this is the DoD, or the government's way of making this right. So Humana was approached last year to become a partner. And so we've hosted pinning ceremonies and thank you ceremonies and recognitions really all across the country. We had one yesterday in San Antonio, in fact. And so again, kind of keep an eye out. These come to a theater near you. If we do one in your neighborhood, we always try to alert all of our partners. We really kind of reach out across the aisle to everybody and say, if you know a Vietnam veteran, please send them, because this is it's not about Humana. It's really kind of a thank you and a welcome home for them. So we really try to get everybody to show up to these. All right, so let's dive into it. Let's talk about the opportunity. So right now there's 9 million Medicare eligible veterans across the country. So those are 65 and up, obviously, for the most part. If you count their spouses, that number goes up to about 14 million. 1 in 5 of the homes that you guys are walking into each and every day are veteran, or they're very, very closely linked to a veteran. So they're the mother, daughter, sister, brother, son, something like that. They have a direct family member in line. So we run into these every day. And for those of you, I know we've got a few agents in Texas that dialed in today. For those of you in Texas, I think the number is close to 1 million Medicare eligible veterans just in Texas alone. So I think it's by and large our largest state with regards to Medicare eligible veterans. So we need to know this stuff. because we're coming in contact with them, especially during AEP. You're running into them every single day. And if you look down here through these next few bullet points, they may overlook available military healthcare benefits. They don't know if they can use VA healthcare and have Humana coverage. And to be perfectly honest with you, if they're in a VA and they're talking to a service officer, a lot of times that service officer does not know much about Medicare. And so that's the situation where you have a VA, you have a Vietnam vet that says, hey, I'm aging into Medicare. What do I need to do? And that service officer, because they don't know any better, may say something like, well, you've got the VA, you're fine, you don't need anything. And so today's training, I hope, will kind of educate you and prepare you to kind of counteract that a little bit. And we are doing work with veteran service officers, by the way. We are in talks with the VFW to start doing some training with their service officers that they have, so that they're aware of this, so that they can really give their veterans the best guidance possible. But until that day comes, it's really up to us to arm ourselves with the knowledge so that we can help these veterans when we meet them. So this is a quick roadmap of what we're going to go through today. I am going to skip around a little bit in this presentation. This is a really long slideshow, but we're not going to go through all of it. So don't worry. We'll jump in with why we ask. That'll be kind of the first thing we do. And then we'll spend probably 90% of our day today going through the Veterans Administration healthcare. So VA benefits, that's 90% of that 9 million number that we saw. That's pretty much everybody. We will spend some time talking about Tricare for Life and ChampVA and how to deal with those folks, but we will spend most of our time today on VA because that's where most of our opportunity is going to be. We'll spend a little bit of time talking about healthcare VA eligibility, compensation, and then how everything kind of ties into Medicare. And then really these are just some wrap-up slides. This won't take us very long at all to talk about how we track veteran enrollments. There may be some prizes and some incentives for you all to really track and annotate on your applications who your veteran members are when you see them. So yeah, we'll jump into it. Before we really jump into the why we ask, I want to make sure we level set just a little bit and talk about some terms. So if you were like me several years ago, I kind of thought these were all one and the same. I didn't know the difference between any of them. Couldn't have told you what they were, but these are all different programs. So I want to start at the top here and talk about VA healthcare. VA healthcare is healthcare for veterans, reservists, and National Guard who meet eligibility and qualification requirements and receive treatment at a VA facility. So what you can do is you can actually think of the VA as, in a way, you can think of it as workers' comp for the military. Now, that's not 100% correct all the time because veterans can qualify for the VA financially, and we are going to talk about this shortly, so put a pin in that. But most veterans, I would venture to say most veterans qualify for the VA because they have some type of a service-connected injury, disability, disease, or illness that came as a result of their service. So me personally, I'm a VA patient. I have a 10% disability with my right knee. Blew it out during a training exercise in California. So I qualify for the VA that way. So it is in a lot of cases it's workers' comp for the VA or for veterans. You can kind of think of it in those terms. Tricare. Tricare is healthcare coverage for active and retired military and family. Can be used anywhere Medicare is accepted, so it's very much like a med sup in that way, that they can go anywhere where Medicare is accepted. It does include drug coverage. And if you notice, I just said it's for retired military and family, or active and retired military and family. So me personally, because I still serve in a Guard unit, I have access to Tricare still. But if I get out of the military tomorrow, I lose access to my Tricare. However, if I stay and retire with the Guard, if I finish out my 20 years, then I actually am allowed to take my Tricare with me and keep it, for the remainder of my life, as long as I pay those premiums. It's a very, very, very good coverage, very rich, very affordable. Once I become eligible for Medicare, age 65, I am required to enroll in Part A and B. And then once you put Medicare and Tricare together, that's what we call Tricare for Life. So Tricare is Tricare until you hit Medicare, and then once you add Medicare onto it, it becomes TFL. So if you've ever heard those two things, Tricare and Tricare for Life, and thought, what's the difference, or didn't think there was a difference, that's the difference, is really once you add Medicare to it. And if you notice, again, it says and family. So this can be obviously retired or active military, and their families can have this. If you look back up here at VA benefits, this is for the veteran and the veteran alone. You're not gonna have a dependent or anybody like that that's enrolled in VA, the VA healthcare system. We'll talk about ChampVA in a minute, but that's kind of the difference. VA healthcare, again, because it's kind of a workers' comp for veterans kind of situation. You're not going to have spouses or dependents in there. If you go down here to ChampVA is the former name for the Tricare program. So you will hear this from time to time. You may have an older veteran in front of you, or they may be DOD, retired DOD or something like that, because the DOD still refers to Tricare as ChampVA for some reason. The reason it's important for us to know these terms and definitions is because this term right here, ChampVA, looks a lot like this word right here at ChampVA. And so I'm sure if you all have sold for more than 5 minutes in the Medicare field, you've all gotten this phone call from your prospect, and they say something like, "Hey, I want you to come enroll me in that zero premium Medicare supplement you have." And we all know they're probably talking about a Medicare Advantage, but they just use these terms interchangeably. They don't really understand the differences between them. The same thing here. Somebody may tell you, "Yeah, I've got ChampVA," and they may be actually talking about ChampVA, or they may say, "I've got ChampVA," and they're actually talking about Tricare. So it's really important for us to know the definition. So if somebody were to tell me I have ChampVA, I'm going to say something like, "Okay, so you are retired military, right?" And they would say yes, or they may say, "Well, no, my spouse was retired, or my spouse was in the military." And at that point, I'd say, "Okay, so that maybe they fall into the ChampVA bucket." You're going to have to ask a few more follow-up questions. So that's kind of why we put such a premium on knowing the definitions here. So let's talk about ChampVA real quick. ChampVA is healthcare for the family of a veteran severely injured or who died in or as a result of their service. Very rich coverage for those who have Medicare. So this is almost like a cross between these two things. So this is going to be the spouse or dependent of somebody who served. Typically, in most situations, they didn't have Tricare. Typically, they would have had VA healthcare, and if they're 100% disabled or they were killed as a result of their service or as a result of the injury from their service, then the spouse and the dependent would receive what they call ChampVA. So it's kind of a gray area. We don't see it quite as much, but they are out there. So we're not going to spend too much more time on that. That's really going to be it. I just wanted to make sure we level set on that a little bit. If you have further questions about that, please, like John said, send those up, type those into that box, and we'll make sure we answer those for you. But I hope that kind of helped to maybe draw a line between some of these different programs that they have. All right, so let's talk about why we asked the question, "Are you a veteran?" By the way, everybody sees this lovely laptop skin. If you would like one of these, I will send you one. If you'll simply just email me, and again, I'm sure John will send out my contact information, or we can put it up at the end again, ddavis21@humana.com. If you'll email me and tell me that you were on this training, my requirement when people ask me for one of these is I say, "Have you taken the training yet?" And if they say no, I tell them they have to take the training, and then I'll send them one. So if you're on here, then and you would like one of these, let me know, and I'll ship one to you. These are great people stoppers. I can't tell you how many airport lobbies, coffee shops, hotels that I've been stopped in and somebody said, "Hey, I'm a veteran," or "Hey, what does Humana do for veterans?" or "Are you a veteran?" It's a great conversation starter. More than that, it's really a reminder for you all. So I have one of these on my laptop. And for me, it's just a reminder that every time I'm in front of a prospect or a Medicare beneficiary to be thinking about this. Are you a veteran? Because this is kind of a loaded question. So I do want to talk about why we ask this question. It's a warm-up question, but it's also a fact-finding question. You can get a ton of information out of a prospect by simply asking this question. So when I'm doing my warm up, I do a little acronym. I follow an acronym called FORM, and you may have learned it differently, but the way I learned to do a warm up is family, occupation, recreation, message. So I start with family. I ask them about their family. Do you have family in the area? You know, my family's from here. Where's your family from? So on and so forth. And honestly, what I'm doing, I'm getting to know them, but I'm also kind of looking for referral opportunities. So if they say, well, I have a brother in Fort Worth, or I have a sister in Arlington, or wherever it may be, I'm taking notes, because at the end of the presentation, I'm going to come back and give them additional business cards and say, hey, have your brother call me, or have your sister call me, or your uncle, or whoever. And then when I get to occupation, I'm asking him, hey, do you still work? Are you retired? What did you do? Where did you work? Because if they spent 20 years at the phone company, guess what? They know other people that retired from the phone company. So I'm going to be kind of working that referral angle. But I always ask, are you a veteran right there? Because if they retired from the military, if they did 20 years in the Navy, that was obviously their occupation. They were a Navy service person. But if they went to Vietnam, if they did a year tour in Vietnam, that was their occupation for a year. It changed their life. It defined who they are. It's probably how it shaped their worldview, and it defines how they see things. So I always ask, are you a veteran right there? Hey, what did you do for a living? Are you a veteran? Do you know any veterans? Did you serve in the military? Something along those lines. Now, again, I thought that's a great warm-up question. If you have somebody in your military, in your family that's military, or you're a veteran yourself, that's obviously what you need to be talking about. If somebody says, yeah, I served in the Navy, and your grandfather fought in World War II, or your uncle served in Vietnam, you talk about what's closest to you, and be sincere, and that you can have a conversation with them about it. So it's a great warm-up. But more than that, it's a fact-finding question. Because if I ask, are you a veteran, and somebody says, yeah, I did 20 years in the Navy, well, 20 years is a military retirement. So now I'm thinking, okay, they probably have Tricare for life. And so now I can kind of start asking some loaded follow-up questions to kind of get me to that point. Or if they said, yeah, I served a year in Vietnam, or I was in the National Guard for 10 years, and that's really all I did. And whatever the case may be, it's going to give you kind of an idea of maybe what type of military health care they may or may not have. Because again, if somebody went to Vietnam for a year, there's a pretty good chance that they have VA benefits. And if they're not accessing them, they at least probably qualify for them. So, and we're going to dive into all that here in just a minute. But it's not just a warm-up question. It's actually a fact-finding question in a lot of ways. And again, keep in mind that veterans know other veterans. So when I ask this question, I don't personally even ask, are you a veteran? I say, do you know any veterans? Because everybody knows a veteran, and it's just an easy way to get people to kind of say names. And so, do you know any veterans? They may say, well, yeah, I'm a veteran, and all my buddies down at the VFW are obviously veterans. So now I'm thinking, okay, maybe I've got an in with this guy's VFW post, or maybe I'm talking to somebody and they say, well, yeah, the guy in my Sunday school class at church is a veteran. So again, now you've got an in to that Sunday school class and his friends. So it's a very, very loaded question to ask. So that's kind of why we came out with a sticker. I'm gonna go ahead and go through these real quick. We did have this training on our Market Point University online. Or on Vantage. We no longer have it up there. We've taken it down to update it, and I'm not sure when it's going to be back up. But until then, we do provide these webinars and these we do live trainings all over the country, but we can always do a webinar. So kind of keep an eye out for that. I'll actually be this is a closed session just for Premier, because we love you guys so much. But we do actually offer a kind of an open webinar every month. So if you do want this refresher training, we'll be having one, I believe, mid-July. And we haven't gotten it nailed down exactly the date yet, but once we do, we'll send it out to everybody so that you can jump on that if you want. So sometimes it's not always just about making the sale. We also ask this question, are you a veteran? So that you can have conversations with people, so you can show interest in them, and so that you can help them, because maybe there's not a sales opportunity there, but maybe they qualify for VA benefits and they've never really thought about applying, or they didn't want to mess with it. If you can give them a little more insight into that and kind of explain to them what they're missing by not having VA benefits, you've helped that person. You've broadened their healthcare options. And at the end of the day, that's why I want to be in this business. I want to be in this business to help people. We make great money, and it's a great industry to be in. But at the end of the day, I want to feel good about what I've done. So that's why we do it. All right, so let's dive into the VA. And again, we're going to kind of put Tricare for Life and ChampVA on the back burner for now, because we're really going to laser focus on VA benefits for the next several slides. So kind of put those things out of your mind for now. The quote up here basically says, I don't want to bring up VA benefits. I don't want to ask somebody if they're a veteran because I don't understand VA benefits, and they're going to realize I don't know what I'm talking about. So that's the kind of the old phrase, or the old saying, is that when people don't know what to do, they don't do anything. And so that's really what we're trying to prevent here. We want to make sure people are armed. None of us are going to be experts by the end of this training, but you are going to know enough to where you can really dive into this with somebody and really kind of figure out what kind of healthcare they have, maybe what options they have, and kind of prescribe the best plan for their situation and really provide a service to them. So that you don't have to be afraid to bring this question up, to bring this topic up anymore. This is a quick map of just veterans and DoD medical facilities across the country. So what I always say is, we can all name, the top providers, hospitals, specialists, primary care providers, you name it. We can all name those in our areas, but can you tell somebody where the local, VA hospital is, where the local VA clinic is? So hopefully you can. If not, get on Google and type in VA facilities near me. Don't type Kentucky unless you live in Kentucky. So you'll get Kentucky. But if you're in Dallas, type in VA facilities near me or VA facilities in Dallas, and you'll be able to locate not only the VA offices, but the hospital, the clinics, some of their COBOT clinics, things like that. This is just a kind of a partial list of some of the healthcare services. The VA is a healthcare system just like any other system. So they have everything. They've got primary specialty, inpatient, preventive, emergency, surgical, so on and so forth. They've got everything. Up here at the top, this is what a typical VA clinic would look like. And then down here is a hospital. And this is almost exactly what our hospital in Little Rock, Arkansas looks like. So a lot of them kind of take on this design and look very similar. So I'm going to let you guys memorize this slide real quick. If we didn't have everybody muted, I'm sure you'd be laughing. Don't worry about memorizing the slide. It's kind of daunting. We did pull this directly off va.gov, which, by the way, you can go to va.gov and fact check and kind of follow up on a lot of the information if you want more information on some of these things. But we pulled this slide off of there, and it's very, very busy. I understand that, but I don't want you guys to get intimidated by this, because I'm going to make this really simple for you in just a moment. Priority groups, once you get into the VA system, if you have a veteran who's a VA patient, he's going to have a priority group assigned to him. He's either going to be a 1, 2, 3, 4, or anywhere through 8, based on his evaluation that he got from the VA. So I'll make this really simple for you all. There's priority group 1, and there's priority group everybody else. And that's really what you need to remember. And we're going to go through that here in just a minute, but that's it. You don't have to memorize any of the stuff on this slide. There's some things I'm going to teach you here in a minute, but there's priority group 1, and then there's everybody else. So don't get caught up in all these definitions or anything like that. If you want to go to va.gov and print this off and have it on you, that's great. It's great to have, but you don't need it when you're in the home. So don't worry about that. So what a priority group is it determines what your veteran is going to pay once they're inside the VA. It does not have anything to do with their wait list or how long they're going to wait to see somebody or how quickly they get in. That's kind of a myth. And you'll hear that. Even the veterans think that. They'll think, well, I'm a priority group 7, so I'm never going to get in to see anybody. And that's just not how it works. Priority group 7 just determines what they're going to pay, what their copays and cost shares are going to be once they go into the VA, because it's not free for everybody, which is another misconception. So let's go through just the first couple real quick. Priority group 1, veterans with VA-rated service-connected disabilities that are 50% or higher. So let's stop there and let's go back right here where it says VA-rated service-connected disabilities. So kind of going back to the workers' comp example, a service connection is basically it's a workers' comp claim. They have an illness, injury, disease, disability that they incurred from their service in the military. So yes, it could be a combat-related injury from Vietnam. It could be, somebody that took shrapnel or they were, they took a round or something like that. But it could also be somebody that worked in a warehouse and had something, fall on their arm or anything like that. Anything like that that's job related to their job in the military. That's a service-connected injury, illness, disability, disease. Any of these veterans that have 50% or more rating by the VA, and again, the VA rates them. It's not an SSDI thing. It's the VA. The VA will put them through a series of tests and appointments and things like that, and they will determine a rating. But if they're 50% or higher, they land in priority group 1. Priority group 2, going down to the next one, veterans with VA-rated service-connected disabilities that are 30 to 40% disabled. Priority group 3, this is where I am personally, veterans who are former POWs. I'm not a POW, by the way. Purple Heart medal recipients or 10 to 20% disabled. So I have a 10% disability. So that's how I qualify for priority group 3. So on and so forth. We're not going to go through all these. I just wanted to give you a quick idea of kind of how they're organized and what it means. And again, has nothing to do with the wait list or anything like that. Strictly determines really the veteran's disability and what, or their rating and what they're going to pay once they go into the VA. So this next slide, hopefully we'll start to tie it all together. So veterans rated at the very top, it says veterans rated 50% disabled or higher do not pay copays. So veterans who are rated 50% higher, going back to this slide, are priority group 1. So priority group 1 doesn't pay anything. Everything's free for them. For the most part, everybody else is going to pay something. So as a general rule, your priority group 2 through 8 are going to have a PCP copay and a specialist copay. And so that's why I always say there's priority group 1 and then there's everybody else. So if you have a veteran in front of you and they say, yeah, I'm a vet and I go to the VA for this, this, and this, and you say, well, what, if you don't mind me asking, what priority group are you at the VA? They may say, I have no idea. And they probably know. But if they don't, what's the follow-up question you can ask them? You can ask them what they pay when they go into the VA. If their answer is anything other than 0, then they're priority group 2 through 8. And that's really all you need to know. If they say, I don't ever pay anything when I go into the VA, then you can probably pretty safely assume that they're priority group 1. And that they don't have to pay for anything when they go. And we'll talk about why that's important in a later slide. But once again, veterans rated 50% disabled or higher, priority group 1, don't pay anything. So VA healthcare is affordable, but not free. And again, if you're like me a few years ago, I thought you serve in the military, you get out, and you go to the VA, and you get everything for free. That's how it's supposed to work. And it's not how it works for most veterans, actually. So there's priority group 1, and then priority group 2 through 8 kind of lives down here. So as a general rule, and there are always exceptions to the rule, but as a general rule, your priority group 2 through 8 folks, when they go to the VA, they have a $15 PCP copay. When they go and see a specialist at the VA, they have a $50 copay. Your priority group 7 and 8, they're going to have cost shares and copays associated with their hospital stays at the VA. So why is this important information for you all to have? Well, if you have let's say you have a Humana plan, or really, fill in the blank, really any carrier, your lead product, let's say you have a $0 PCP copay. And this veteran is telling you, I don't need what you've got because I've got the VA. Well, what priority group are you, sir? Well, he says, I'm priority group 2, or I'm priority group 5, or 7, or 8. Okay, he's probably paying $15 every time he goes to the doctor. So this may be a really good time to bring up the fact that you have a $0 PCP copay. Well, sir, what if I could save you $15 every time you went to the doctor? And by the way, you didn't have to go to the VA for it, which, by the way, the VA is not a fun place to go to. There may be some weirdos out there that like it. I personally do not. But that's one of those things that's kind of important to know. So I always tell my students, I always tell my agents that, you when you're taking this training, either physically or mentally, start making a checklist. So this needs to go on that checklist. So when that veteran says, I don't need what you've got because I got the VA, put down $15 PCP copay at the VA. I can save you $15 every time you go to the doctor, or I can save you 10 or 5 or whatever it may be. That's important information to have. The same thing with specialists. I did this class in Louisville, Kentucky last week for a group of our new agents, and one of the guys is going back to Florida where they have a $0 copay for the PCP and a $0 copay for the specialist. So he can save veterans $50 every time they go to the specialist and $15 every time they go to the doctor. So kind of look at your lead products and apply that information appropriately. But this is good information to have from a sales standpoint. Let's kind of keep going with drug coverage. So number one, VA medical is not creditable coverage with regards to Medicare. Don't ask me why. It's just not. However, drug coverage is. So if you do have a veteran that's delayed Part B for any reason, and we run into that, his VA medical coverage, if he delayed Part B, he's still going to end up getting a penalty later if he enrolls. And we'll talk about that soon. I've got a slide for it. But if he took Part B and he had Medicare and he has his VA drug coverage, he's good. He's covered. He's creditable because the drug coverage is creditable with the VA, but the medical is not. So that's kind of one of those weird things. Most of you are all probably already aware of it, but that is a reality. So again, priority group 1, they're not going to pay for drugs. They're not going to have any kind of copay or co-insurance or anything like that when they fill those prescriptions. Priority group 2 through 8, they are going to have some cost shares and copays. So let's talk about these real quick. So Tier 1 preferred generics at the VA pharmacy are going to be $5. Tier 2, $8, and then Tier 3 name brands are going to be $11. And now, when I was selling, I would have loved to have had $11 name brand drugs to sell. That would have been phenomenal. $5 and $8 is not so much. It's not too terrible, but as you all probably know, if somebody goes through Humana mail order pharmacy, they get their generics. They get a 90-day supply shipped to their door for $0. They don't pay anything for it, which is phenomenal. So think about this, and we haven't really talked about this yet. The VA does not coordinate with any other coverage, and that's good. That's a good thing. We don't want them to, meaning that when a veteran goes into the VA, they're going to pay the VA rates. And if that veteran has a Medicare Advantage plan, when they go to their Humana doctor, they're going to pay their Humana copays. The two are not going to crisscross. They're not going to coordinate or anything like that. They are just based on where they are. Those are the rates they'll pay. So that's really good. So apply that to this situation here. You have your pharmacy. So they can get their generics through us for $0, which is really, really cool. But our name brands are not $11. They're a little more expensive than that. They get $11 name brands to the VA, so they can actually tailor their coverage. They can actually get their generics through the mail order pharmacy, obviously if they have one of our plans, and get those for $0, and they can continue getting their name brands from the VA for $11 a pop. And now you've really helped this veteran really tailor their coverage and really save some money and kind of get the best of both worlds. So it's just kind of a neat thing to be able to sit down with somebody and kind of work through those things. So down here it talks about a $700 annual cap. This is not how you and I understand it. It's not a coverage gap. It's not a donut hole or anything like that. It's a $700 annual cap. Essentially, it's their max out of pocket. So once they've spent that in the pharmacy, that they don't pay for anything else. Everything else is covered for them. So it's a positive thing for them. So some people see that at the bottom and they freak out a little bit, but it's a positive thing for your veteran. So that's drug coverage. usually I usually have already gotten this question by the time we get to the slide, but we've got everybody muted. So the VA will not refill or rewrite prescriptions prescribed by your private physician. If you see a non-VA provider and want to have scripts filled by the VA, you must meet the following conditions. So I'm not going to go through all these, but essentially what the VA will tell you, whether you go to the website or you call them, is they're not going to fill a prescription from a Humana primary care doctor or a specialist or anybody like that. So that's kind of the book answer. I will tell you that in a lot of cases they actually will. You need to be prepared for the fact that they may not. So a lot of times what happens is if we have a veteran that walks a prescription in, he walks his little paper prescription into the VA pharmacy from his Humana doctor. Most of the time what happens is the pharmacy tech calls his primary care team at the VA and says, hey, I've got a veteran down here and he's wanting to fill his prescription for metformin or whatever it may be, but it's from an outside doc. What do you want to do? What they're probably going to do is check his chart. If he's ever gotten that drug before from them, they're going to say, well, he's gotten it before. It's not a red flag. Give it to him. So that's what happens a lot. If it's for a narcotic, some kind of a painkiller, that's going to throw up a red flag. Most of the time, they're going to say, we want him to come in and see us first, and let's talk about this before we fill that. So that's kind of the hit or miss situation, I guess. So if you end up having a veteran in front of you that has an issue with that, that the VA may fill outside prescriptions, but they don't have to. But again, it's some systems are better than others, so you kind of have to just kind of feel that out in your own community and your own VA, and it's still veteran dependent. It's going to be dependent on each person and their individual situation. So hopefully that didn't confuse anybody. It's just not a black and white situation. It's kind of a gray one. Let's talk about advantages and challenges with the VA healthcare system. So one of the advantages is they understand veterans. That's the only population they work with. They understand them better than anybody. They have everything there that a veteran needs, really. They've got service officers there that can help them, if they need to file a claim or if they need to get connected to more benefits. They've got those people there. They've got everything there. I will tell you from experience, it's still a big, cold government hospital. So it's still not a whole lot of fun to go to. My personal experience is when I go in, I'm a number. Let's fix what's wrong with you and get you out of here because we have a lot more veterans to take care of. So it's not that they don't care about veterans, it's that they have a lot to do and they're understaffed. So that's kind of the reality of that situation. Other advantages are they help people who need it the most per financial status or disability. So again, like we talked about earlier, here's the workers' comp piece. They deal with these veterans that have some type of a service-connected issue, but they do also take care of vets that through financial status they can't afford anything else probably. And I'm going to give you guys the specifics on that in a moment. So a couple different ways to qualify. It is affordable. It's not free like we saw, but it's certainly affordable coverage for those that are eligible for the VA and qualify for it. And then, like we just talked about a moment ago, they can have VA and other coverage like an MA plan or an MAPD or a PDP, and the two are not going to coordinate. So that's a positive thing. Challenges: it's not available to all veterans. So I have a friend, he's one of our sales managers down in the Houston area, Matt. He's a 5-year Air Force veteran, discharged honorably, served honorably, all that fun stuff, but he does not qualify for VA benefits because, number one, he doesn't qualify financially. He's full-time employed with Humana. That puts him over the limit. And then number two, he doesn't have any kind of a service-connected injury, illness, disability, or disease. So he doesn't have any kind of workers' comp claim with the military at all. So he does not qualify for the VA. So you may run into that situation, although I will tell you that most Vietnam vets are eligible and qualify for VA benefits. It's not 100% of them, but the majority of them. Access to facilities. This is a challenge. Access to facilities, travel is often required. So we just kind of made this list of reasons or ways to tell a veteran that he kind of needs what you have, or ways that you can tell him that, look, I could probably save you some money. So we talked about the PCP copay, the specialist copay. We talked about the prescription drugs. Well, think about this. Travel often required. Me personally, I can drive to Little Rock. I live in a suburb. I live outside of Little Rock, so it's going to take me anywhere from 45 minutes to an hour to get to Little Rock with traffic. I would gladly pay more money just to go and see my doctor here in town. If that's an option, I'm going to take that one every time, because I don't want to burn half a day, an entire day, driving, fighting traffic, waiting, parking, the whole 9 yards. When you go to the VA, it's a big mess. I would much rather see somebody locally. So it may not be a cost issue with them. It may be a convenience issue. Somebody may live 5 minutes from the VA, but somebody also may live 2 hours from the VA. So that's something to consider as well. They may love just the idea that they can go down and use their Humana primary care doctor, which is right down the street, and use the pharmacy at Walmart to fill their drugs instead of going to the VA. And they may gladly pay, the additional copay for the name brands to go to Walmart or Kroger or CVS or wherever instead of going to the VA, because it saves them from having to drive to the VA, to the pharmacy, to fill that prescription. So kind of think about those things too. It's not always a cost issue. Sometimes it's kind of a convenience thing. Many physicians choose private practice rather than working through the VA. It's kind of a really nice way of saying that the best doctors don't always go into civil service, and we're not knocking VA doctors at all. We have some wonderful doctors, we really do. But a lot of times the doctors that are at the top of their class, when they graduate, I mean, the reality is the majority of them go into private practice, or they go into a large practice to pay off those student loans. Most of them don't go to work for the VA right out of the gate. Second opinions or access to best and specialty physicians may not be readily available. So with second opinions, think about this. Think about it this way: the VA cannot contradict themselves. So if you have a veteran that gets a diagnosis or a prognosis or anything like that from his VA doc, he cannot go to another VA doctor and get told something different. They can't contradict themselves. So you'll run into this, and many of you probably have if you've been doing this for any length of time. You'll have a veteran that says, well, I want something so that I can go outside the VA and get a second opinion if I want one, because they've run into this. They've said, well, I disagree with you. I want a second opinion. And the VA basically says, tough luck. So they may want to pick up a plan. They may want to enroll with you just so that they have a backup option. I think they may not intend on using it. They just want to have it in case they need it. So those are advantages and challenges. Let's talk really quickly about the Choice Care program, because this is something you will run into, or you have run into, I'm sure. The Veterans Choice Program, which, by the way, the VFW is responsible for getting that legislation passed in order to have that. The requirements for this program are that a veteran lives 40 miles or further away from a facility, not a hospital, but a facility. So that could be a clinic or anything else. Or it's going to be 30 days or longer before they're going to be able to get in and see their provider at the VA. And so what the Veterans Choice Program is it's basically an overflow network for the VA. So, if the VA is understaffed and they're busy and they can't see somebody within this 30-day window, or if somebody just lives too far out, then the Choice Program is basically an overflow network of private hospitals, specialist physicians that agree to see VA patients, and that VA patient will pay the VA rates. And so it's just like Humana or Aetna or Cigna or any other carriers out there. We all have to go out and build our networks. Same thing here. The VA goes out and builds a Veterans Choice Network so that their patients can go outside the VA when they qualify. What I will say is it's not the silver bullet. Sometimes you'll have a veteran in front of you and he'll say something like, well, I've got the Choice Program, so I can go anywhere I want, anytime I want. I don't have to pay anything. They give me a free puppy and a lollipop when I go. It's wonderful. And that may be the case, or they may be pulling your leg a little bit. Or maybe in their area, wherever they're at, the Choice Care Network is really, really good. But it's not that way everywhere. So the Choice Care Network is only as good as the VA in that area has made it, as much as they've built it. So it's not 100%. It doesn't mean that they can go anywhere and everywhere. It just means they can go to the places that the VA has established. So again, in Dallas, they've got a great choice network. In Las Cruces, New Mexico, not so much. So it kind of dependent on where they're at. I put funding up here in red because it's kind of iffy on how long this program is going to be around. I think they're working on a replacement for it. It was actually only supposed to be funded through January of this year, but they passed a continuing resolution to keep funding it for the unforeseeable future. So it's, as we get more news and more updates on that, we'll clue you guys in and try to push those out to you. But just so you're aware, you will run into that. You'll hear this word or you'll hear this term, and you'll have somebody tell you, I can do anything I want because I've got the choice network. And you can kind of run that through your own filter because, maybe it's working great for them, or, if nothing else, you just understand, it doesn't mean they can go anywhere everywhere. They can just go where the VA's built the network. So that's what that is. All right. Let's shift gears just a little bit and talk about emergency care at the VA facility. So if you are all making that checklist on why a veteran needs us or ways that we really provide a great service to a veteran, this right here, this slide needs to go at the top of that list. This is probably the single biggest risk, the single biggest exposure our VA patients have with regards to the VA. Now, again, keep in mind that if it's a priority group 1 veteran, that they're not going to pay anything. So the scenario here on this slide is a non-VA facility. So somebody has an emergency, they have to go to the emergency room, they're going to Baptist Hospital, or they're going to Coleman Carney, or they're going somewhere like that, versus going to the VA because it's an emergency. They've got to go to the closest one. A priority group 1 person who goes to one of those facilities, he can go into the ER with a paper cut, and the VA is going to pay the claim. He doesn't pay anything. Everybody else, priority group 2 through 8, they are going to run that claim through a series of filters to see if they're going to pay the claim or not, to see if it qualifies. So again, a very busy slide in front of you. Don't feel like you have to read it all, but I did highlight some very important words for you. And down here we have and. So we highlighted the really important words because if you notice, it doesn't say or, it says and, which means that veteran has to fulfill each one of these criteria in order for the VA to pay that claim. So the scenario might be that you have a veteran, priority group 2 veteran, that goes to a non-VA facility, goes to the ER with a broken leg. And the VA is basically going to say, how bad did you break it? So right here, based on an average knowledge of health and medicine, it can be reasonably expected that a delay in seeking immediate medical attention would have been hazardous to your life and health. So they may say, okay, well, if the bone's sticking out, that's pretty hazardous. We'll pay that. But if you just kind of fractured your shin, you probably could have waited a few more days and come into the VA and been just fine. We're not going to pay it. So that they're going to kind of run it through that filter. So they've got all these different checklists. So at the end of the day, the horror stories that you might hear would sound something like, well, my buddy went to a non-VA emergency room and the VA rejected the claim. They sent it back to him. Well, who got the bill? The veteran got the bill because if VA is the only coverage he has and the VA denies the claim, he's stuck with the bill. So it may be a $2,000 bill, maybe $5,000, maybe $10,000, who knows, which is very sad. However, if he's got an MA plan in place and the VA rejects that claim, then all the hospital does is refile the claim through Humana, and now he's subject to an $80 copay for the ER. Or, if he stayed in the hospital, he's subject to those copays. But either way, it's much better than nothing, which is what he had before. He was responsible for the entire bill. So this is why I say it's the single biggest opportunity you have with veterans. Again, if they're priority group 1, they don't have to pay, so we have a different conversation with them. They don't really need us, but there are some ways we can make ourselves very attractive. We'll talk about those in a minute. But for everybody else, priority group 2 through 8, my personal opinion is that they need, if they qualify for Medicare, they need what we have, because this situation is possible at any time. A veteran's not going to pull this list out and say, well, hold on, honey, before we go to the emergency room, let me make sure that I would qualify to have the VA pay for this. None of them do that. They go to the emergency room, they get treated, and then they find out after the fact, will the VA not pay this claim for me? So we spent a little extra time on that one, but there's a reason. It's very, very, very important, and it's the biggest risk that your clients are going to have. All right, shifting gears a little bit more, we're going to talk about healthcare eligibility. So again, if you're like me, the guy on the screen says, if you're a veteran, you can go to the VA, right? And again, that's what I thought. You serve in the military, when you get out, you go to the VA, no problem. Not necessarily the case. Like I told you with my friend Matt, he served 5 years and he does not qualify. So who's eligible? Veterans who served in the active military, naval, or air service, and have, as long as their discharge does not say dishonorable. It can be other than honorable. It can be general, medical, honorable. As long as it's not dishonorable, they're fine. If they're dishonorable discharge, they're not going to get VA benefits, period. Reservists who served full-time and for operational or support, National Guard members. So again, you all do not need to memorize this slide. This is, honestly, it's not important. Basically, if you meet somebody that says they served in the military for a day, your question should be, well, are you receiving VA benefits? And if they say no, I don't qualify, or I've never applied, they need to apply. If it's been more than a year since they've applied for VA benefits, they need to apply, because somebody could have stepped off the bus at basic training and broke their ankle, and they may have a permanent disability now. That's a service-connected injury. They may end up getting VA benefits out of that. So we don't ever want to count anybody out. We're not qualified to do that. We're going to basically suggest that they call the VA or go and talk to a service officer, which we'll talk about in a minute. We'll give you the tools to help them do that. But we don't triage them. We simply ask if they've ever applied for VA benefits, and if they haven't, we point them in the right direction and say, we think you should give it a shot. So a couple of different ways to qualify. So their service is what makes them eligible. Again, if they kind of going back up here, if they're a veteran, a reservist, National Guard, they're eligible. In order for them to qualify, again, like we talked about, they can qualify financially or through a disability. And I didn't build this slide presentation, so we got a guy in a wheelchair, we have a hearing issue, we have I'm not sure what's going on here, so I just always laugh at that slide because I don't know what this means. But so they can qualify through financial means or Egyptian hieroglyphics, either way. So let's talk about financial real quick. These are financial thresholds, and these are across the country for the most part. There are geographic adjustments no matter where you're at. So this is kind of the benchmark here, $32,000 a year. But then you also want to run that through the Harris County filter, or whatever county you're in. You can basically just Google VA national income thresholds, and then you can find out what your local area threshold would be. So if you have a veteran that's close, they may say something, and we run into this a lot. You may have a veteran that says, well, I served, but I was never injured, or I never did this, or I never did that, so I don't qualify. But they're on Medicaid, or they're on LIS or something like that. They may qualify financially, and they may not know that. And so this is a time where you can kind of step in and say, well, you qualify for LIS or Medicaid. Have you ever applied for the VA financially? Because you may qualify through financial. So just a way for you to kind of offer that up for people. So let's move on to service connection, which is going to be where most people live, right? This is going to be how most folks qualify for the VA. Service-connected injury or disability, disease or injury incurred or aggravated while on active duty, does not have to be combat-related or wartime-related. Examples would be PTSD, TBI, brain injuries, hip, knee, foot, arm, hand injury. That's, I obviously have a knee injury, vision or hearing loss, amputations, heart disease, skin conditions. There's a number of things. So again, we don't ever discount people. We try to get them to go talk to the experts. We just need to know enough to point them in the right direction. So this is how they apply. This is how they actually get connected to their benefits. There's a few different ways. Number one, they can go through, go and fill out the paper form, VA form 1010EZ. As an agent, I used to always have these in my bag. I had Medicaid forms, and I had half a dozen other things, but I always had Medicaid forms and I always had 1010EZ forms. It's not really the easiest way for them to apply, but back when I did it, that was really the only way that you could do it. Now it's much easier because they can either call this 800 number or they can go to va.gov and apply either way. So that's, again, we're going to get you the cheat sheet so that you have all this is on the cheat sheet. So you don't need to write this down if you don't want to, but those are kind of the two easiest methods for them. The best method, though, would be to talk to a service officer. So they can call and talk to somebody, through the 800 number there. They can go online and fill out the little questionnaire, and somebody will get back to them. But if they go and sit down with a service officer, that service officer is going to know what questions to ask them. And just to tell you, when I did it, when I walked into the VA and talked to a service officer, he asked me half a dozen times if I had PTSD. And I got a little irritated with the guy because I was like, if you ask me this question one more time, I might get there. But looking back, he was asking me in different ways throughout the appointment, and he was kind of seeing how I responded, because not everybody that suffers from PTSD knows it, or some people won't admit to it. And so that's kind of why he was asking, because if he could determine that I was suffering from it, there's an additional disability, an additional percentage he could get me, and he'd get me more benefits. So that's why we say that the service officers are really the best people for them to talk to. Another thing is if I'm missing a service record, if there's a piece of paper or an infirmary record that I'm missing from my time in service, that service officer is going to know how to go find that. He's going to have resources to go and pull that, from a database, or have somebody send it to him so that he can make sure that veteran gets that additional level of benefits that they're entitled to. So that's why we always say they're the best people to talk to. So a few different ways to find service officers. Number one, they can go to vfw.org, or honestly, they can walk into a VFW. I've done it many times where I've gone and met with service officers across the country, and I'll walk into a VFW hall, and a lot of times there's a bar, and you go up to the bar manager and you say, hey, when is the service officer here? And they'll say, well, they're in the corner right now. They're here for another couple hours, or they come in on Tuesdays and Thursdays between 3 and 6 and talk to people. So walking into the VFW or go to vfw.org is a great way to find them. You can also go to nacvso.org. That's the National Accredited Veteran Service Officer Organization. That's kind of a county listing of service officers. So you can go in there and again, if you're in Texas, you can click Texas, and then you can click, whatever county you want, and then it's going to pull up all your service officer options there. It's going to have contact information right there for them. You can also walk into a VA regional office or VA hospital, VA clinic. Most of them are going to have a veteran service officer on staff in the building most days, 9 to 5. So there's tons of them out there. The DAV has their own. The American Legion, they have service officers that come and sit in their posts. So really, almost any veteran organization you talk to, you should be able to dig up a service officer there. All right, so let's talk about compensation. When we talk about VA benefits, we're talking about the healthcare portion of it, but there's also a compensation portion of it. And so this is the chart right here. So based on the percentage, and we've all kind of talked about these. So going back to the priority group slide, priority group 1 guy is going to be where? Right here, 50% or higher. 50% or higher. A priority group 2 guy, he's going to be 30 to 40, so he's going to live right here. And then a priority group 3 guy is going to be 10 to 20. So this is where they're going to be. So me personally, I don't mind sharing with you. I'm priority group 3, so I get $136.34 deposited into my account every month. All like clockwork. It doesn't get taxed because it's not income, it's compensation. It's the Army broke something on me and they're paying me for it. That's kind of what it is. This is important because you may end up running into a veteran that basically says, nah, I don't want to go to the VA. I've never wanted to mess with it. You know, my buddies didn't like it, heard bad things, what have you. He may not even be aware that there's a compensation benefit portion to all this. So, and the really cool thing is they will back pay you. So we've had people, you know, go and apply for VA benefits that they've qualified for since the 70s. And now all of a sudden they get back paid all that time that they would have been receiving compensation. The VA just strokes them a big check for all that time. So there's a significant portion here. And I'll tell you one other story. I was doing this training in California, and I had one of our associates in the room, and she came up to me afterwards and she said, you know, my father's a Vietnam combat veteran, really tough guy, you know, but he's always been stubborn about going to the VA. He's never filed for benefits, and I've never pushed it because I didn't know. And after sitting through this, she goes, I'm the one financially responsible for all of his health care. And he doesn't go to the VA, which has never really been that big of a deal. But she's like, I didn't realize that he got money. So now she's thinking, well, you know, that money could really help, like, come in handy with taking care of her father, especially as he gets older. And so that's something else to think about. You may not be really talking to the veteran. You may be talking to the veteran's spouse or their child or their caretaker, because it may be somebody else who's financially responsible for them. So just kind of keep those things in mind. If you get up to the 100%, this would be somebody who, you know, their spouse is probably ChampVA. This would be who that is. The veteran could be ChampVA if the veteran would be VA, but they'd be 100% disabled. Their spouse would be ChampVA. So they may be getting, you know, upwards of $3,000 a month, depending on if they have spouse or dependent in the household, and then it kind of goes down from there. So if you want to look at this yourself, this one's up to date. It's from December of last year, but if you go to va.gov, you can type in the little search bar just compensation, and a compensation chart will pop up there. Let's talk about presumptive service connections. This is why I said, you know, if you have a Vietnam veteran in front of you, more than likely they're going to qualify for VA benefits, strictly because of presumptive service connection. So presumptive service basically means that they were exposed to something, and the VA cannot prove that whatever health conditions they have now were not as a result of their military service. So they can't prove that it did happen, but they can't prove that it didn't happen either. So they just kind of get a rubber stamp automatic approval into benefits. So the biggest, the most popular one is Agent Orange. So this is a picture of Vietnam. You got a helicopter here spraying the jungle down with Agent Orange. And Agent Orange is basically Weed Be Gone on steroids. They sprayed it on the jungle to kill the foliage so that we could find the enemy easier. They wouldn't be able to hide from us. The bad news is later we found out it was really, really, really bad for you to come in contact with. So a lot of our infantry, a lot of our guys that were out in the jungles, that were out on patrol outside of the base, they were exposed to this stuff. The pilots, the crews that loaded it, the warehouses, anybody that worked in the warehouse, they were all exposed to it. So basically the VA says, look, if you were in country, if you went to Vietnam, doesn't mean you fought, you know, you might have worked in an office somewhere, but they can't prove that you didn't, you know, come in contact with this stuff at some point because you were in close proximity. So they call that a presumptive service connection. So at that point, again, they just give them a rubber stamp. And I don't remember exactly. I think they get around 60 or 70% automatic. But Agent Orange causes cancer, diabetes, coronary artery disease, Parkinson's, and a lot of other bad stuff. So if they have anything like that, the VA basically has a list, and if they have any one of those conditions that they've been diagnosed with, they're probably going to get VA benefits awarded to them. with it. And again, we have a lot of veterans that they don't think they qualify. They may say, well, I worked in a warehouse through Vietnam, so I was never injured or anything like that. But they have they have artery disease, or they've got cancer or diabetes or something. They may not realize those two things are connected, and they probably are. So there's money on the table. There's benefits to the VA on the table. We need to make sure we're connecting them with those. So anybody that served in Vietnam in country between 62 and 75, anybody in the demilitarized zone in Korea between 68 and 71, and this is only a couple of them. Everybody, there's tons of stuff out there. There was a water contaminant issue in Camp Lejeune here in the States, which is a Marine camp. So anybody that served there during a certain period of time, the VA will ask these questions. When you go to the VA, they have a series of questions they ask. Did you serve here, or here? Were you okay? You served there. Were you there between this year and this year? And then they go through it from there. So there was I think they're giving presumptive service connections to a lot of our men and women that were in Desert Storm, because they were lighting oil wells and oil refineries on fire as our soldiers were coming through, and a lot of those people have lung issues and things like that now. So again, somebody may not think they qualify. If they haven't applied for VA benefits in a year, we need to encourage them to apply again, because the VA is always adding to that list. And somebody who did not qualify a year ago, they may all of a sudden qualify. And not only do they qualify now, but they're going to get backdated and back paid for the last 20, 30, 40, 50 years, however long it's been. So that's why this is so important to understand. Because if we can help connect somebody to more benefits, number one, it's the right thing to do. Number two, they're going to love you for being knowledgeable and taking the time to kind of show them the ropes here. We don't really run into this anymore. You may hear this every once in a while. There's no record of my service. I served, but my records were burned up in a fire. It might have been a small warehouse fire on Fort Chaffee in Oklahoma. Or the biggest one was back in St. Louis in '73. There's a big records building that caught on fire and burned up a lot of records. So if that happens, again, if it's been more than a year since they applied, they need to apply again, because even though this happened and they did lose a lot of records, it was not a total loss. So they have found other records since then. We've come a long way with technology since then. So there are other ways to find out if somebody actually served. So don't let them use this as an excuse. Tell them, look, I think you'll probably be able to find. They'll be able to find your service record if you try again. Encourage them to apply. All right. So veterans healthcare and Medicare. Let's kind of tie all this up together. We really want people to have both. You have people on both sides. You have veterans that don't want to deal with the VA. They just want to deal with Medicare. They want private health care, and that's great. That's fine. We want that. But as you've all seen, there are a lot of really good things about the VA. There's compensation. There's the drug coverage is great, especially with name brands. There's a lot of reasons for them to have it, so we want them to have it. And then you also have people on the other side. You have the veterans that they've got VA, and so they don't think they need anything else. But as you all just saw, if you're not a priority group 1 person at the VA, you need something else, if for no other reason than the emergency room exposure. So I hope that's kind of what you got over the last few slides. This is the biggest thing, kind of the biggest challenge or roadblock I think you'll probably run into is I don't need Medicare. I don't need Medicare Part B. I've got VA healthcare, and maybe it's been a couple of years. And so now if they pick up Part B, because they haven't had anything for the last few years, now they're going to face that penalty. I will tell you, I still think it's worth them picking it up, even with the penalty. It's still worth them picking it up, because at the end of the day, yes, it's going to be more money per month to pay for the Part B with the penalty, but can you afford a $5,000 ER bill, or can you absorb a $10,000 ER bill if you come in contact with that? And that's a real scenario. So Down here is a quote from VA.gov. The VA does not recommend veterans cancel or decline coverage in Medicare solely because they are enrolled in VA healthcare. So that sounds good, but I will tell you, a lot of service officers, that's not what's coming out of their mouths. What's coming out of their mouths is you don't need Medicare, you've got VA. And honestly, it's just because they don't understand all the different traps and scenarios and exposures that veterans still have if they're not Priority Group 1. Okay, so I do want to talk a little bit. We talked about Priority Group 2 through 8, but let's talk about Priority Group 1. They don't need anything else. They really don't. I mean, they don't pay for anything in the VA. They can go to the VA pretty much, or the ER pretty much anywhere, and the claim's going to get paid. They've got a pretty good deal. They're getting great compensation from the VA, but they still may be interested in enrolling in an MA plan, and there's a lot of good reasons for them to do it. More choices in providers. So again, it's not always a cost issue. It may just be a choice issue or a convenience issue. Again, maybe they're a Priority Group 1, but they still live an hour or two from the VA and they don't want to have to drive. Second opinions. They may still want a second opinion. Plan extras. They may just want to enroll in one of our plans because it's got a silver sneakers benefit on it. Or maybe they want extra dental and vision and hearing. Or maybe they want the over-the-counter benefit that some of our plans have. So when you're talking to a Priority Group 1 person, those are really the things you need to kind of focus in on and dial in. Priority Group 2 through 8, you're really talking about, copay savings. You're talking about all these things, but you're talking about copay savings. You're talking about ER exposure. You're talking about drug coverage coordination and kind of going to the VA and going through Humana Pharmacy, so on and so forth. So you kind of have to figure out who your audience is at the beginning. A Priority Group 1 person, you're going to have a little bit of a different conversation with them than you would Priority Group 2 through 8. So I hope that makes sense. This is a really busy slide, and I apologize for it. If you want to just shut your eyes, you can. I'll just walk you through it. That's probably easier. And this is our, there's a special election period out there that applies mostly to veterans. There's no SEP strictly for veterans. There's not I can switch plans anytime I want just because I'm a vet. Unfortunately, that does not exist. However, this is the SEP OCC. So it stands for Other Creditable Coverage, and this most often applies to veterans. So I'll just explain it to you in layman's terms and give you a scenario, and that's probably going to help you more than actually reading through these bullets. But the SEP OCC stands for Other Creditable Coverage. So the scenario would be that you have a beneficiary that has 2 creditable drug plans. Now, who might that be? That would probably be a veteran who maybe they have an MAPD with somebody and they have VA drug coverage. That's 2 creditable drug plans. So what CMS says is they said, hey, we'll give you an SEP to get out of one of those. Since you have 2 drug plans, you don't need 2 drug plans. We'll let you out of one of them. Well, they're not going to get out of their VA drug plan, obviously. So they'll give them an SEP to disenroll from the MAPD. And what it allows them to do is they can either go back to original Medicare or they can go to an MA only. They cannot go to another PDP. So the whole idea is they have 2 drug plans. They can get rid of one of those and replace it with original Medicare or an MA only. They can't enroll in another MAPD or go into a drug plan, a standalone drug plan or something like that. It would kind of be pointless. So this is not going to get you 10 extra enrollments a month, but you might run into these people, once or twice a year. So, at the very least, you wouldn't have to walk away from that enrollment because they may say something like, well, I've got this MAPD with so-and-so, and I really like your MA only plan you have, but I guess I'll have to wait until AEP to enroll. And you can say, not necessarily. Maybe there's something we can do if you're a veteran. So that one's it's a little bit complicated, but tried to simplify it for you as much as possible. Maybe a few opportunities out there for you. Okay, so we're really done with the VA portion, and the good news is that we will not spend nearly that amount of time on Tricare for Life or ChampVA. Not because it's not as important, it really just doesn't take as long. And I'm going to condense a lot of slides into really just a couple of slides here over the next couple sections. So let's shift gears. We're out of VA. We're not going to talk about VA anymore. Kind of like when you go into a home, you don't talk about a fee-for-service and a PPO and an HMO all in the same setting, or at least I hope you don't, because you'll confuse people. So we are stopping the VA portion, and we're going to shift gears and go to Tricare. So once again, Tricare is for active and retired military, and then again, once you get on Medicare and add Medicare to it, it's Tricare for life. So I didn't say this earlier, but you could possibly have somebody that's Tricare and VA, because they may have a service-connected injury, illness, disability, disease. You know, they may have VA benefits that they qualify, but they may also have retired from the military. So now they have Tricare and VA. And a lot of times, Tricare people, they have very rich coverage. They don't typically want to go to the VA anyway. So they'll go out to their private doctors and to the people that are in the Medicare that accept Medicare, the Medicare network. They'll do that versus going to the VA. But that you may run into a few of them that have both. So just be aware of that. Tricare for Life is a premium-free Medicare wraparound coverage for beneficiaries who have A and B of Medicare and Tricare, very similar to a Med Sup. So you may end up with somebody in front of you that says, hey, I've got Tricare for Life, but I'm really interested in your MA plan. And you may be thinking, well, you have a great plan already. Why are you looking at an MA plan? And this is kind of why. They hear about all the bells and whistles, right? They hear about vision, dental, hearing, silver sneakers, over the counter, all the extra stuff that we have on our plans. They hear about it and they want that. So we always tell you a good needs analysis is always the best thing. So let's talk about advantages and considerations on somebody with Tricare for Life. Number one, it acts like a Med Sup, so Medicare pays first, and then Tricare for Life kind of kicks in and pays whatever's left. They do have a $3,000 max out of pocket, but that's for a lot of electives and things like that, because ultimately they don't have any premiums. They don't have a network to stick to aside from Medicare providers. They don't have any copays. Their drugs are built right in. So you can see it's a pretty stacked plan. There's not really a lot of reason for them to look elsewhere. They've got a great deal already. If you put them on an MA plan of any kind, consider these things. Right now they can go to any Medicare provider. If you put them on a PPO or an HMO, now all of a sudden they have a network. You've not given them more options. You've actually constricted their options. You've lessened their network. Plans to make TFL secondary, which they were secondary before. That doesn't really change. Hopefully you're not in. I really wouldn't enroll somebody that's got Tricare for Life into a plan that has a premium on it. That doesn't make a lot of sense. Since they don't have a premium here, why would you put them into a plan that arguably has less benefits, less coverage for a premium? Again, our goal is to leave these people better than when we found them, to help them. We don't want to put them in a worse situation, no matter what scenario we're looking at. You may end up, we put this in here, you may end up, if you have any of these providers in your area, you may have somebody like GenCare, Oak Street, or Iora, somebody like that. With those providers, they have an agreement with Humana that in order for somebody to see them as a provider, that patient has to have a Humana plan. And so you may have somebody that sits down in front of you and says, well, I want to go to Iora. I want to go to that doctor because all my friends go there and they tell me how great it is. But I can't do that unless I have an MA plan. So I know I've got Tricare for Life, but I want an MA plan so I can go see Iora. So at that point, I would really make sure they're completely aware of everything they've got here and what they're getting themselves into. At the end of the day, if that's really what they want to do, we'll do it for them. But honestly, my advice most of the time is going to be not to put somebody that's Tricare for Life into an MA product. It's just, you're not putting them in a better situation. So there's always exceptions to every rule. So again, do the needs analysis, have that conversation, find out why they're wanting to do it, educate that person to the best of your ability. But then, ultimately do what they want you to do. I would say that if you do enroll them in an MA product, you need to make sure you probably do a lot of documentation on what all you told them and about them wanting, essentially wanting to do it anyway, or their reasons for wanting to do it, because those do have the potential to have more Section A's. Because again, at any point, if they're not happy, you're going to have another agent down the road or somebody down the road that says, well, that agent should have never enrolled you in this, and that's why you're having this problem. And they're going to go file a complaint on you, and that's what's going to happen. So not trying to scare you. I'm just saying if you do this, make sure you document and protect yourself. Send an email to your upline or something like that once you do it. And some of the plans have, again, they have extras. They may have a Part B give back or premium reduction, Part B premium reduction, things like that. So those are some advantages and considerations with Tricare. Again, we don't typically recommend that you enroll those people into an MA plan. And again, if you think back to that 9 million Medicare eligible veterans, the last statistic I saw, it's not official, so don't quote me on it, but I think roughly 90% of them are VA. I think it's only around 9 or 10% that are actually TFL. So, the VA pond is really the private pond you need to be fishing in. So, real quick, if you have a Tricare for Life person that enrolls in an MA plan, now when they go to their doctor or when they go to their provider, Humana they're gonna have to pay the Humana rate. And the good news is that Tricare for Life, in most cases, will reimburse that out-of-pocket expense, that copay. But they have to fill out a form. It's DD Form 2642. They send it in, they get reimbursed. So that's good. But again, you haven't really made it easier on them. It's now they're having to go through an extra step. They're having to actually pay money out of their pocket and then wait for reimbursement. So that's kind of why we say you really need to be cautious about that. So that's as much as we're going to talk about on Tricare for Life and ChampVA. Honestly, and I'm going to skip a couple of slides here because we're going to go straight to this slide because it's very similar to Tricare for Life in the way that it operates with Medicare. So there are different programs, yes, but as far as we're all concerned on this webinar today, they act very similar to Tricare for Life. So again, our cautions are all the same with ChampVA. Act similar to a med sub, no network premium copays, so on and so forth. Kind of take the same approach you would with a Tricare for Life person. Really, really dive into why they're wanting to do it. Make sure you give them all the cautions and explain to them, what they're getting into. And then if they want to do it, go for it. But just make sure you do a lot of documentation. In either of these cases, what we always say is if they're insistent that they want an MA product, we always say put them on an MA only if you can, if it's an option. Really, really try everything you can to avoid putting them on any kind of a PDP or an MAPD because they don't have, they don't have a they don't have a coverage gap with their current plan. If you put them on a MAPD or a PDP, all of a sudden now they have a coverage gap, they have a donut hole. So if you have to do something, do an MA only. All right, so that's kind of the meat and potatoes of everything, really. We're gonna wrap up with just a couple of quick things here, real quick. Tracking veteran enrollments. We all talked earlier about asking the question, are you a veteran? And by the way, we won't even use up. We had 2 hours allotted for this, but we're going to be done here in about 5 minutes. So thanks for hanging in here. We talked earlier about asking, are you a veteran, and identifying who those people were. What we're asking you to do as Humana is when you do enroll one of these veterans into one of our products, we're asking you to track that so that we know where these people are. So statistically, we know that 1 in 5 Medicare beneficiaries is a veteran. And so out of 7 million Medicare beneficiaries, we know we're probably close to the 2 million mark is what we've kind of, just because we've looked regionally, we kind of have an idea of region-wide where most veterans are pocketed. So we have a pretty good guess. But we are trying to actually track that. And this does come back to you because we use this data so that we can market to veterans, so that we can participate in more veteran events. But at the same time, when you guys track who your veteran enrollees are, we're actually, I actually get a report that shows me who the top agents are. And so I'm going to start sending out basically Humana gear, free Humana gear. We're working on some incentive programs that may provide you guys some additional marketing money, so that if you want to go and work with an American Legion at a stand down, or if you want to go to a veterans health fair or something like that, you know, there may be additional Humana marketing money on the table for you to go and do that. Or maybe you want to take out an ad. Maybe you want to put an ad in the VFW newsletter, or you want to put one in the newspaper around Memorial Day or Veterans Day or something like that. So just kind of keep in mind there, we are trying to make it worth your while. And I do frequently send shout outs and emails and things to our top agents, our top partners. And typically I'll ask them, hey, what's your shirt size? Or, hey, would you rather have a Humana tumbler, you know, like a Yeti tumbler, or would you rather have a, you know, Humana phone charger or a Humana duffel bag or backpack, something like that. So we try to give you guys some swag and reward you a little bit for doing it. But we'll get into how to do it. This will take just a minute. If you use MAPA, really, really simple. Click everything that says veteran if they're a veteran. So if you do that, you can't go wrong. And really, we track the veteran, but we also track the spouse of a veteran. So if you're enrolling the spouse of a veteran, we're really trying to identify veteran households. So that's where we ask, you know, hey, if you're a veteran or if you're the spouse of a veteran, click everything that says veteran. And so when you, right here, it says tier 1 and tier 2. This is the signature page on MAPA. You drop that down and just select veteran. Very, very simple. We are aware that a lot of people primarily use paper, or they go on Fast App or Vantage. So if you're all using paper, it's even simpler. When you get to the signature page on a paper application, just write veteran under campaign. And so I've got it highlighted up here for you so you can see. But that's simple. Whether they're the spouse of a veteran or a veteran themselves, just write veteran into that campaign field. And that identifies them for us. It lets us know who that veteran is, but it also writes back to you so that when I get that sales report, I can see which agents are kind of at the top of the list as far as writing veterans. So you'll get credit for that. And then last, Humana Advantage. So if you're doing any type of online enrollment, again, anytime you're doing it online, just click everything that you see that says veteran, and you'll hit it. So this one's super simple because it's only in one place, and it says veteran. If you drop that down, I know that it's hard to read, but it says self, spouse, or dependent. So you just drop that down and click the appropriate one, and you'll get credit for it from there. So this is where I'm going to wrap it up. This is the engagement guide. Nope, we're not going to look at that. Sorry. Let me pull it up for you real quick. There's an engagement guide I will be sending you all, or actually I'm going to send it to John and I'm going to let him push it out. But this is something we created as kind of a one-page document for you all to kind of have with you. You can have it on your desktop, on your computer, or you can print this thing out. It's two-sided. But it's kind of got the top, you know, things you can ask a veteran. If you just have no idea how to talk to a veteran, here's some things that you can ask. You know, what branch did you serve in? What did you do? Where were you stationed? Are you part of a VFW or VFW Auxiliary or American Legion? That's important because if they are, you know, again, you may have an opportunity to go talk to their group sometimes. So those are all opportunities. Quick reference guide. So pretty much every phone number, every site, every link I referenced today, it's right here. It's all up here for you. So you want to send somebody to our job portal so they can apply for a job with Humana, or again, we partner with 20, 30 other companies to help place veterans with jobs. You know, that's right here, jobs.net/jobs/blah, blah, So that's all right here. Marketing and educational resources. These are our talking points. This is kind of our brag book. Kind of it talks about our hiring initiatives. Everything I talked about in the beginning of the webinar today, it's pretty much all here. It talks about our national sponsorship with Rolling Thunder and the VFW, 6 million veterans on Tricare. This is just so if you're telling our story or somebody asks, well, why are you asking me if I'm a veteran? What does Humana do for veterans? Well, you go right here and it tells you how to answer that question. And then on the back, this is really functional. So if you get a TFL person, you get a Tricare person, they say, I've got Tricare. Here's like the top 5 things you need to know about Tricare. You get somebody who's ChampVA, right here, ChampVA. You get VA, here you go. Here's the top 6 things you need to know about VA. And then over here is how to code those applications on MAPA and on the paper applications. So that's it. So you all get this. I will send this out to John here in just a moment. And I'm going to put my contact information back up here just so you all have it in front of you. And besides that, everybody, thanks for, I know you didn't have a choice, but thanks for being quiet and attentive. But I hope everybody learned one thing. If you learned one thing from this webinar, then it was a success for me and it was worth my time. So thanks everybody for being on.
Hello? Hey, Kevin, are you on the line?
Hello, good afternoon.
Hey, Kevin, it's John. How are you?
Hey, I'm great. How are you, John?
I'm doing fine, thank you. Hey, I got your presentation folded into the overall one, so we don't
Okay.
have to worry about flipping it if you don't want to. You just
Yeah.
tell me next when we get to your part, and I'll slide on to the next slide. So
Okay.
we're ready to roll.
Cool. If you don't mind, can we try real quick to just hand me the screen and see
Sure.
if it'll work when I share mine?
Sure. Are you on the system?
Yeah, I'm in right now.
Okay. We are now kicked over. You are the presenter as of the moment. Can you see my screen?
I'm accepting your invite right now,
Oh, okay.
so it should be kicking over to my screen. You tell me if you can see it.
Yep, sure can.
I just have the go-to webinar thing up there right now.
Yep.
So I did one of these a couple of days ago, and we got on early and did the same thing, and it worked fine before we started the webinar. But then when we did start the webinar and they tried to hand it over to me after they did a couple of their slides, we couldn't get it to show. So that's why I went ahead and sent it to you just in case.
Yep. Well, then let's just roll with not having to worry about switching control.
Okay.
Because I got it folded right into the middle. You just tell me next slide, and we'll slide forward.
That works for me. That's perfect.
Okay.
That works for me. A little pressure off of you and me both.
Fold it back.
Yep.
There we
and
go.
then I see the screen. So, all right,
Cool.
that works.
We should be good. I'll start
Good.
in 5 minutes. We'll have her ready to roll. But she's all folded in, all pretty, and that way we can I can make a PDF out of it and use it as part of the follow-up.
Excellent. That sounds good.
We've got 45 RSVPs. Right now it's showing 7 that are logged in. So we got, the people that pop in the moment. But what we'll do is
Yeah.
not only send a follow-up and the list out so people call, but we're going to do another e-blast with the recording embedded in the e-blast where they have to register to see the recording, and then we can get kind of double fruit out of it, hopefully.
Nice. Okay. That sounds great.
So that's my story, and I'm sticking with it.
Cool, man. How have you been?
Doing okay. How about you? You've been traveling quite a bit.
Oh, yeah, man. I've been on the road a lot. I'm in Phoenix right now, actually.
Yeah, so what is it, about 2,000 degrees?
At least. I think it's either that or they pretty much just go ahead and say surface of the sun is what it feels like.
Yeah,
yeah, it's hot.
We were out there in July a couple, 2 or 3 years ago for a carrier rollout, and at the hotel it had the metal handrails down steps.
Ooh.
And I was walking, there were 3 of us walking to take a picture by a big old cactus plant. And I let my arm touch that metal railing. Ooh. It burned my arm.
Oh, wow.
It was that bloody hot. So
that's insane. Wow.
Yeah, you got to be careful with that stuff, I guess. So.
For sure. Yeah, I went to a meeting yesterday, and it started at 11, so it wasn't the peak of the day, but still already pretty warm. And I wore a sport coat and walked in, and I went to the wrong side of the building, so I basically ended up having to walk around the whole outside. Oh man, I was drenched in sweat by the time I got to the right office.
Wow. God bless heat.
Yep, I'm telling you. I am telling you, but they don't respect us here. Like in Texas, they think, oh, y'all aren't that hot. We get pretty hot too.
Yeah.
Maybe not, desert hot, but we get pretty hot. But I've heard it's been raining this week and been a little cooler, right?
Well, I haven't seen any rain, but it's been overcast the whole week and looked like it was going to rain. So,
oh, wow. Okay. Well, yeah, I live a little further up north, like north of McKinney, and my wife and my son said we got a pretty good chunk of rain yesterday and a little bit on Monday also.
Good. We got sprinkle, and that was it.
Yeah. We'll take any little bit we can get.
Absolutely. Well, we're up to 10. Oh, cool. Total. 8 attendees. We count as 2.
Right.
But we'll stock we'll stock them all, but get information out.
My experience with these is usually people tend to jump on right at the start time or maybe even a few minutes after. So I expect the numbers will go up. Maybe not hit 40, but, at least scare 40.
We'll get the follow-up out anyway and follow-up calls and see what we can do. So thanks for doing this, by the way. So much appreciated.
Man, anything. Yeah, it's my pleasure, man. Anything for Premier, anything for you. So anytime you want to do something, let me know.
We'll schedule maybe one next month or so for the Med Sup.
Sure.
That work?
Yeah, we can do Med Sup. Yeah, and that's a pretty quick one. If you wanted, we could even throw on an extra 10 minutes and do the dental again with that too, just to kind of pique their interest beyond the Med Sup.
Sure. Cool. I'll get one scheduled and then invite out to you or get one scheduled and see if the dates work, and then we'll get it going.
Yeah. Sounds good. I don't have a lot on my calendar for July right now, so hopefully should be pretty open.
Okay. Well, we're at 1 o'clock. I'm going to go ahead and get her started. I'll do a run through of a few slides and then turn her over to you. Just tell me when to change the slides. Cool. Thanks, brother.
Will do. Thank you.
The broadcast is now starting. All attendees are in listen-only mode.
Folks, thanks for coming on the line with us today. My name's John Dubas with Premier Marketing, and we'll be spending the next hour or so going over a portfolio of supplemental insurance products brought to us by Aetna with the Aetna Senior Supplemental Insurance Products portfolio. We're using this as part of a campaign to help you fill the holes and augment your income stream to yourself and your agency. A little bit about Premier and a little bit of housekeeping up front. Today's presentation is being recorded. It and the PowerPoint of the presentation will be sent to you as some follow-up along with some additional information, and that will come to you within the next day or so. A little bit of information about Premier Marketing for those of you who aren't familiar with us. We are one of the national marketing organizations that is part of the Integrity Marketing Program. We have offices across the country. We work with independent insurance agents, offering them vested contracts at the highest possible commission levels available, with recruiting contracts available for those who qualify. We are celebrating our 50th year this year. So we are an organization that not only has the financial backing of the Integrity Marketing Program, but also a history in the insurance industry with a widespread portfolio of products. We are one of the largest organizations when it comes to marketing Medicare product. In the Medicare Advantage arena, we are the largest organization with 3 of the carriers, United Healthcare, Anthem, and Meridian, and among the top 5 with just about every other carrier that you can imagine. As I mentioned, we do offer a full portfolio of products, not only Medicare products, but life insurance, short and long-term care, and ancillary products, much like the portfolio we're going through today. And that Medicare Advantage portfolio is a very robust portfolio. You're going to see a lot of information come out about these programs in the next month or so, so watch for some additional information in that regard, along with additional information on the prescription drug programs, the Part D plans that are available as well. Our Medicare supplement portfolio includes an offering from Aetna that is a very competitive product, so watch for some additional information on future webinars in that regard in the very near future. So we'll spend today featuring the Aetna Senior Supplemental Insurance products and speak to the portfolio of programs that are available to us through contracts with Aetna. Now, keep in mind, these programs are available through a contract that is separate from the Medicare Advantage contract, but it is something that we can most certainly take care of you with very easily. Our featured presenter today is Mr. Kevin Moore, and he's the Regional Sales Manager for the West for the Aetna Senior Supplemental Insurance products. And at this particular point in time, I'm going to shut up and let Kevin take it away and tell me what to do when it comes time to push the screens. Kevin?
Hello, good afternoon or good morning, wherever you may be. Good day to everyone, I should say. And thank you for having me on. Thanks to everyone for taking the opportunity to spend a little time with us. And thanks to Premier and thanks to John. I just want to start off by saying that Premier is an excellent organization. John's an excellent partner to work with, as is all the people with Premier. So you're getting top-notch quality when you deal with this organization. And congratulations again to them on their 50th year in business. So with that being said, John put my info up here. If you guys would like to take a moment and note my email address, please do so, and my phone number. I welcome your calls. I actually cover the Western United States. So if you're in that territory in one of the states that's listed there in the bottom left-hand corner, that's great. I'm your go-to guy. If you're not, that's okay too. You can still call me. And towards the end of the presentation, I will give you the contact info for the people that do actually work your region in case you want to reach out to them as well. So with that being said, we'll go ahead and flip over to the next slide. And let me just give you a little quick background on our division of Aetna. So we are called Aetna Senior Supplemental Insurance. Basically, we're the old Continental Life company, if you guys have heard of that. It's an old Medicare senior product company that's been in business for over 30 years. We're just owned and operated for the last 7 or 8 years by Aetna, which is a great place for us to be and a great place for Aetna to be. At this point in time, we pretty much manage all of the Medicare supplement business for Aetna, as well as our complete portfolio of cross-selling products as well, which is what we're going to talk about today. So real quick, just to review or just to give you a heads up on where we are and what we're up to most of the time. Our office is based in the Nashville, Tennessee area, actually in Franklin, which is a suburb of Nashville. If you're ever in the Nashville area and you'd like to come by and visit, we love to host agents. So please let us know. You can contact me directly. I'll be happy to set up a meeting with you at the home office with some of our folks there. So keep that in mind. We have a very dedicated agent services team. That's a top priority for us, is making sure that you've got the type of support that you need if and when you have an issue with your business, getting commissions, getting policies issued, whatever the case may be. And the same goes for our client services team. So we are also there to take care of your policyholders if and when they experience any problems or issues. We're very focused on business persistency. That's important for you and important for us. We do our absolute best to give you products that are very competitive in terms of not only value and features, but also rates. You know, we want to offer a product that's going to be competitive in terms of what you're going to pay as a client. So that's something that's a top priority for us. We also want to reward you with the highest possible commissions that we can. So we do our best to make sure we've got a great commission structure so that you're getting well compensated. And then we have growing renewals. Most, if not all of our products actually have growing renewals in terms of having lifetime commissions. So you always will have a renewal stream coming in. And then, as I mentioned before, we give you cross-selling opportunities. So our core product is the Medicare supplement, but we've completely designed a list or a portfolio, if you will, of products that are there to help fill in the gaps. As you know, Medicare wants to pay less and less, and that means more of the burden's falling on your actual individual Medicare subscribers or your clients. So we're trying to help give some products to the market to help make sure that we can fill in those gaps. And that's what we're going to cover today. You can go ahead and flip it for me, please, John. Real quickly, we're also an A-rated company by AM Best, which classifies us as excellent. That's good for you to know and good for your clients to know, of course. We operate under 4 separate charters or entities, which are all listed here. It's going to be Aetna Health and Life, Aetna Health Insurance Company, American Continental, and Continental Life. Now, all of our products are branded big, bold letters in the forefront of our kits as Aetna. So you will see Aetna, but you'll also see one of these side brands there. These are just the different entities that allow us to operate and file products with the states. You will see them, but by and large, you're going to see Aetna more than anything else. Go ahead, next slide, please. Real quickly, I always like to share this with everyone that I speak with because I think that this guy, he's our president and CEO, Ty Woolridge. I think he has a very good understanding of the senior market and what it takes to succeed and what it takes to do well. And he's a great leader for us. He always has interesting things to say. And here's an example of something that he put in our newsletter that we do every month, a few months back. It's called the Pace Setter. Hopefully you're getting that in your inbox every month from us now. If not, certainly let's get you appointed and registered and get you signed up because there's lots of great info in there. And Ty always writes a piece. And this is just one line out of an article that he wrote. And it just really resonated with me about who we are as a carrier and what we're trying to accomplish. And he just says, we want to be the last insurer that your clients ever need or want, and for as long as they live. Next slide, please. So here's a list of all the products we currently offer. Our core, again, Medicare supplement. We also offer a final expense, cancer and heart attack or stroke, which we're going to cover today, hospital indemnity, and the new version of that, the Flex Hospital Indemnity, our nursing facility care, and the newer version of that, which is called Recovery Care, Home Care and Home Care Plus. And then our newest, latest, and greatest product is our dental, vision, and hearing. And everything from the cancer, heart, and stroke down, we're going to talk about a little bit today. Here's just a quick listing. One thing to know about us is that not necessarily are all of our products going to be available in each state. So I would recommend that you go and pull our product availability chart. I know this one's difficult to see, but just so you know what it looks like, if you go to our website, you can open up the latest version and see exactly which states have which products. So always check that to make sure that the states that you're working in are going to have the products that you'd like to present. So we're going to go ahead and kick it off first and foremost with the cancer and heart attack or stroke. This is one of my favorite products to talk about. I'm a big believer in it. I'm actually a policyholder myself. As you can see, it's available in just about every state. Some of the few states that it's not in are usually going to be states that we just don't do a lot of business in general, but we're covering most of the country there. Next slide, please. So what I suggest to everyone is that make it a point, if you're not offering a cancer or a critical illness product now like this one, go ahead and get in the habit of it. It's very valuable coverage that anyone can really use and benefit from, and I'll show you why in a minute. But basically, the way you would want to open up a conversation with anyone is, just start off with the simple basics. Do you have cancer coverage? Most people do not. Do you know anyone who's had cancer? I promise you most people do. And you can start a whole conversation from there and start showing the value of why it's important to have that type of coverage. My general statistic is that if you speak to 10 people a week, just go ahead and mention it. Ask everyone that you talk to, and I can promise you, you're going to sell at least 3 just for asking. So that's opportunity for you to help your clients and also put more money in your pocket. Go ahead, next slide, please. So I won't go into all the stats here. I'll just leave this up here for a few seconds or a few minutes for you to look at it. As you can see, the illnesses that this plan covers are very high risk for everyone. There's a great potential for any of us to be affected by these illnesses, and it's a sad truth. I mean, a lot of these, there's not a lot we can do. We can do our best to live healthy, but these illnesses that are out there are really, very non-selective in terms of how they attack. Anyone can get hit with these illnesses at any time, and it can be usually is completely unexpected. So my recommendation is share this information with your clients. If you get our enrollment kits, you'll see this exact page that you're looking at now is going to be in the kits. Share it with your clients. Let them know what their exposure is. Let them know what their risk is. And the thing that most people don't realize or understand, and you can go ahead and hit the next slide, please, is that most of these illnesses, well, not most, all of these illnesses, they're very expensive. They're going to hit you where it really hurts, in your financials. And you can see some stats here. 3 out of 5 bankruptcies are due to medical bills, and 20% of all adults in the U.S. struggle to pay those medical bills. Nearly 61% of all cancer treatment costs are indirect, meaning non-medical expenses. And that's something we don't think about. Cancer especially, the treatment is very long in most cases, and sometimes that treatment isn't available to you right down the street. Many times you're traveling, sometimes out of state, to get the type of treatment that you need for your cancer. I've heard countless stories on my own of people who had to spend a month at a city that's hundreds of miles away getting treatments every day at a specialized facility. Unless you are fortunate enough to have free room and board there, then you're going to be paying for the expenses to not only get there but to stay while you're there. Last time I checked, it's not cheap to live in a hotel for a month. So keep these things in mind. I don't care what situation you are in life, whether you be a senior or even under the senior age, you can be affected by these illnesses and can be very, very exposed to the financial factor of it. And I'll just, I can talk forever about the financial impacts, but I'll just share a personal story with you that really makes sense to me and kind of helps me understand why it's good to have this type of coverage. So my mother was diagnosed with brain cancer 15 years ago, and she survived for 18 months before she passed away. During that 18 months, my brother and I, we were the only caretakers. We spent more time stressing and worrying and losing sleep over how are we going to pay for all the specialized things that she needs? How are we going to cover these expenses instead of just spending time with our mom? And looking back, that's one of the biggest things that I wish I would have known or I didn't, realize at the time. It was before I was in the insurance business, so if that helps at all. So keep those things in mind. My mom is one example, but this can happen to anyone. Go ahead, hit the next slide for us, please. So here's how the product works. The issue ages are 18 to 89, except in the state of California, it's 18 to 64. So when you're working 18 to 89, you can write it on just about anybody. So it doesn't have to be just for your senior clients. And I always like to mention to everyone that, obviously premiums are higher when you're older. When you're, elderly, you're going to pay a higher premium for this type of coverage. Don't let that deter you from starting that conversation. Bring it up anyway. And you may find that maybe your older senior client isn't as concerned for themselves, but they may want to buy it for their children or their grandchildren. Keep that in mind. So the way it works, again, is it's a lump sum benefit that's paid directly to the policyholder. And that's important to know. Some other carriers may have similar products out there right now that do not pay a lump sum. They pay you based on receiving treatment. With us, it's a lump sum paid upon diagnosis. Benefits can start as low as $5,000 or can be increased as high as $75,000. You choose that time that you are writing the policy or buying the policy. I personally have a $50,000 family plan. And I tell you that because I'm going to use myself as an example as we go through this. So you do have one optional rider that you can tack on. It's an ICU rider. I'm going to tell you more about that in just a minute. You can choose to do an individual plan, an individual and a spouse or a domestic partner, an individual with children for like a single parent, or you can do just a straight family plan, which covers everyone in the family. I have a family plan that covers myself, my wife, and we have 3 children between us. So all of them are covered, all for the same amounts and all for the same 3 illnesses. When it comes to children, your premium doesn't increase based on the number of children. It's going to stay, once you buy a family plan, regardless of how many children there are. If you have 3 or you have 13, which thank goodness I don't have 13, they're all going to be covered, and it's no additional premium. By the way, children are also covered until age 26 or until they're financially independent, which they're never financially independent, so it's going to be age 26. And it's going to be, again, the same lump sum benefit for everyone on the policy. And so here's where I'll use myself as an example to help you understand how it works. So if I were to be diagnosed with cancer, I would receive a $50,000 benefit. Now, that means I've used the benefit for myself. I can't ever use the benefit for cancer for myself again, but it does not affect the benefit for my wife or my children. They're still covered for the same amount for cancer. Now, let's say that once I'm diagnosed, I get my lump sum, and then I beat cancer and I get healthy, and the next thing you know, several years down the road maybe, I have a heart attack. Well, then I get another benefit at that point. So when that happens, that policy doesn't really do anything else for me, but it still remains in effect for everyone else that's covered. So you can get a potential of 2 benefits. You can't do 3. Now, you may be thinking, okay, but what about heart attack or stroke? Well, with heart attack or stroke, that is one or the other, not both. So it's a kind of a matter of whichever happens first. Now, once you've had both occurrences, then really that policy doesn't do much else for you. If you were the only one on the policy, then it would terminate at that point. But in a family plan, it's going to remain in effect for everyone else. So hopefully that makes sense to everyone. The whole purpose of this is to help offset out-of-pocket expenses. As we discussed, the expenses involved with these types of illnesses can be very, very devastating, to say the least. Benefits are, again, paid upon diagnosis. There's no hospitalization required. And that's an important thing to know, because maybe a person doesn't want to get treatment. Maybe they've decided, I've lived a good life. I'm going to take my chances. I don't want to go through the grueling treatment. And then they're certainly entitled to do that. That's not going to affect your benefit. So if they want to spend that money and go take a vacation, or they want to go, buy a boat, that's certainly their prerogative. And that's not a problem with us. It's a 30-day waiting period. So once you buy the product, you can't get diagnosed with anything for the first 30 days. So keep that in mind. You might want to advise your clients of that. And then one unique feature that I really like about this product is that the youngest partner can be placed as the primary. And why is that important? Because the rates are going to be tied to the youngest partner. So if you have a spouse situation with a large age gap, then that's something you want to keep in mind. Or even just a small age gap can make a big difference as well. I ran into a person a couple of months ago doing this same presentation. And as soon as I mentioned that, she's like, oh my goodness, I need to buy a policy right away. And I said, okay, why? She goes, well, my husband is almost 30 years older than me. And I was like, yes, gosh, you need to buy a policy. I mean, that's a huge savings for that couple to be able to buy a policy tied to her, who was in her probably late 20s, early 30s, and then a husband who's, almost 30 years older. So that's a big difference. So that's a good thing to keep in mind. You can go ahead and hit the next slide for me, John. So this is the intensive care unit rider that I mentioned before. You can add this on. It's very cheap to add on, and I think it's very well worth it. It will pay $150 per day for confinement in the ICU, but that's only for 1 unit of coverage, the 150. You can add up to 4 units, and each unit is worth $150 daily. So if you were to max it out with all 4 units, then it would actually be a $600 daily payout. And that's huge, and it works for 30 days at a time in the ICU. And not to mention that you don't have to be in the ICU because of one of these critical illnesses on the policy. It doesn't matter the reason you're in the ICU. It can be for anything. Let's say you were in a car accident, you broke your hip and needed to be in the ICU. Well, then this benefit would certainly trigger. I do want to make a note, the benefit for the rider decreases by half at age 65. So your rider at that point, instead of being worth $150 per day, each unit is going to be worth $75. So you could get up to $300 if you max it out at 4 units. So, and again, that's just for the rider, does not affect the lump sum. There is no reduction in the lump sum ever. Go ahead and flip it for me, please. Okay, I want to also mention that this is a simplified underwritten product. So that means that you can basically go through the entire app, and the only thing you can expect to answer are going to be yes or no questions only. And if they answer all the questions correctly, then the policy will be issued. The only other thing you have to take into consideration is there's going to be a field underwriting guide, which will have prescription drugs in it that you need to check. There is going to be a few, potential knockout drugs there, so keep that in mind. Go ahead and next slide, please. And by the way, you can write this using our e-application, which if you're not familiar with our website, it's aetnaseniorproducts.com. Once you log into our website, you have e-apps available for pretty much all of our products, except a few that aren't, they're not really more of our popular products anyway, but this product and all the ones I'm going to talk about today are available to be written through our e-application. And you can do that right over the phone. You don't have to see the client. If you're out there working really hard during AEP in the fall, and then you want to follow up with all your clients in the early, winter in January, February, you can do it without going to see them. If you want to follow up and sell them a cancer plan or any of the plans that we're talking about today, I always like the concept of that myself. Real quickly, I'm not going to go through the app. I just wanted to show you kind of what the app looks like. It's a one-page app. This is the top part of the page. I couldn't fit all the entire one-page app on one slide, but this is the first half of it. As you can see, it's all yes or no questions. And if you'll flip to the next page, the bottom half of the app is on the next page. And there you go. And if you look, the bottom fourth of this, or the bottom half on this screen, is just the questions if they're adding the ICU rider. So if they're not adding the ICU rider, really it's only less than a page. It's like 3/4 of a page. So, and if you guys would like apps, let me know. I can email them to you, or if you'd like to go to Premier, they can get that information to you as well. I would suggest reviewing it. See if you have any potential candidates for this product. Go ahead, next page, please. So just to review, 18 to 89 are the issue ages. And one note on the issue ages, I had a question the other day that kind of worried me, so I always like to mention this. Those are your issue ages. That doesn't mean that if you can't use the product after age 89. Your product is good for life if you make sure you buy it before you turn 90. But once you turn 90, if you already have the product, it's not terminated or anything like that. Someone the other day in a session I was doing was concerned that they lose their coverage when they turn 90. That's not the case. You just can't sell a policy to someone over the age of 89. It is a lump sum benefit, as low as $5,000 or as high as $75,000. As I mentioned, it's simplified issue. You can write it using our e-app also. There's an ICU rider that's an option. You can do an individual and spouse, or domestic partner, individual and children or family. It's the same benefit for every covered person on the policy. It's to help offset out-of-pocket expenses. Benefits are paid upon diagnosis. No hospitalization or treatment is required. 30-day waiting period, as we said. Youngest can be primary. And then I put a note down here at the bottom because this question usually comes up. What about skin cancer? Skin cancer is covered as long as it's the serious form of skin cancer, which is called malignant melanoma. If it's more of a simple version like a basal cell, no, that would not trigger a benefit. It's got to be the serious form of skin cancer. And that's pretty much all I had on the cancer, heart attack, or stroke. And I'm not sure that I or John mentioned this, but your line's obviously muted. If you do have questions, use the chat or the questions feature in the webinar application, and we'll take those questions at the end of the presentation. With that, we're going to move on to the next product, which is our Hospital Indemnity Flex. Really excited about this product, especially if you're working in the Medicare Advantage market at all. This product pairs very well with any MA plan, and even, it doesn't even have to be an Aetna MA plan. It will work with any MA plan out there. But you're better off if you can bundle it with an MA plan from Aetna, because that helps increase your persistency. It's found to be more likely that a client is going to keep several products from the same company instead of having mixed matched and moving them around. So just kind of food for thought. So this is kind of the strategic map that we have laid out. This is a fairly new product. We haven't quite got it launched in every state, but as you can see, everything that's green, the darker green, it's already there, and the lighter green, and actually those two states, Arizona and New Mexico, they have been launched since this map was printed. So the gray states, red and black, are not there. The gray we hope to get soon. The red and black probably will never get. So just kind of food for thought on that. And if you could go ahead and flip to the next screen. So I, recommend, this is a product that can work for anybody, by the way. Its issue ages are the same as the cancer product. It's 18 to 89. So even if you have underage clients, people that are on, Obamacare or a situation where they've got a company plan with a high deductible, they could benefit from a plan like this. So keep that in mind. This can supplement really any type of coverage. Anyone who's concerned with paying expenses that occur as a result of a hospital stay or outpatient services, such as a doctor visit, a surgery, or rehab. And, the way you would start a conversation, do you have a hospital copay or deductible? And if so, do you have money set aside for these out-of-pocket expenses? Most people don't. That's why they're buying, a cheaper plan in most cases anyway. Go ahead, next screen, please. So with this plan, we've designed it to be very flexible, and you have the ability to cover everything listed here. Hospital confinement, that's the base of the plan. You could add on skilled care received at a nursing facility, doctor's office visit, outpatient surgical procedure, ER visit or ambulance service, a cost associated with a cancer diagnosis, outpatient rehab, and then just as a footnote, again, it's issue ages 18 to 89. And I can't prove this for a fact, but I've been told that if you get highly proficient at marketing this product, you will, in fact, be able to do this yoga pose that you see here. So keep that in mind. I hope everyone's laughing or at least chuckling a little bit. Next screen, please. Okay, hospital indemnity base. So you have to, when you go to build one of these products for your client, choose a base option. There's two options. You have the first option, which is a hospital admission indemnity. It's a lump sum payout, basically. And then you have your second option, which is a daily payout. So when you go to design the plan for your client, you have to choose one or the other here. I would recommend, personally, I'm a big fan of the daily over the lump sum, and I'll kind of walk you through and explain why. Let's start by talking about the lump sum first. So it pays a lump sum amount for hospital confinement, including, and this is very, very important to note, this does include observational stays. So keep that in mind. That's a big, big thing we all need to be concerned about. If your observation stays aren't being covered, then you're, as a client, are getting hit with big bills potentially. So it's available in units starting as low as $250, which that wouldn't be much of a lump sum, or you can increase it as high as $2,500 for a maximum payout. It's payable once for each new period of care. A period of care is 60 continuous days without treatment. So what that means is if I was to use the lump sum and I went into the hospital, I would get my check for whatever amount we, bought a policy for. And then once I'm out of the hospital, I can't benefit that same benefit again, use that same benefit again for 60 days continuously without treatment. So that's a little bit of exposure. That's why I prefer the daily. And by the way, on the lump sum, if you were to choose that option, what I kind of would do is look at their plan, look at whatever kind of plan they have, whether it be MAPD or whether it be, like a regular major medical plan for someone who's younger, of course, then look at what their exposure is, especially on the MA plan. So let's say that, on average, most MA plans, if they end up in the hospital for 4 or 5 days, they're usually out of pocket somewhere between $1,200 and $1,800. So just look at that and then build your lump sum according to that. That would be my suggestion to you. But if you look at the other option, like the daily hospital, then I think you've got better flexibility here, and I'll explain why as we go through this. So it's going to pay a daily amount once they go in the hospital. It does include observation stays. It's available in units of $10, and you can increase it as high as $700. So again, look at their other coverage, see what their daily exposure is, and increase it to that amount. And then you also have to choose the number of days that they want to have covered. So you have a little bit of flexibility there in terms of if you chose, let's say, 5 days, okay? Let's say you chose 5 days, you went in the hospital for 3 days. Well, you're going to be entitled to benefits for 3 days of daily payout, but you still have your 4th and 5th day in reserve if you happen to get sick again in a week or two. So that helps, in my opinion, to avoid that period of care, the 60 days continuous. So you can kind of beef up your number of days that you have covered. And then if you end up in the hospital just for a few days and you don't use all of your days, then that way you still, if you happen to get sick again, end up in the hospital, you've got some other cushion there to help you. So other than that, you still, once you do, go through all of your number of days, then you're exposed again to the 60-day waiting period to be able to have the benefit again. And then also on the daily, if you end up in the hospital for less than a full day, you still will get half of your daily benefit. So that's not a bad deal at all right there. So those are your base options. Hopefully that makes sense to everyone. Let's move on now to the riders. And you've got a whole slew of riders that you could potentially add on here. This one's a big one. The first one that we're looking at here, daily skilled nursing. I think it's very important to add this coverage on for anyone, because as we know now, what's happening with hospitals is they want to get you out as soon as possible. So you may not be well enough to go home, but you're not sick enough to be in the hospital, so they're going to send you to skilled nursing for several days or however long it takes. Once that happens, the exposure can get pretty high as well. So with this, you can add $200 per day, and you can choose the number of covered days, either 1 through 20, 21 through 100, or days 1 through 100. So you've got the ability to cushion the blow there with this option. Then you have a doctor's office visit indemnity, which I always thought this was kind of a silly rider personally, but I can't tell you over the last couple of months, in fact, even yesterday I was presenting to a group in Arizona, and they like this. They really like the doctor's office visit, and the more I hear about it, the more I'm starting to like it too. So the way it works is you can get reimbursed for your doctor's office visits starting as low as $10 or as high as $60 if you were to max it out, and you can do up to 20 visits per year. And it will work for a regular doctor visit or a specialist. So, and if you've got someone who's seeing a lot of specialists, that can get expensive. Not to mention, it's a disruption in your routine when you have to take, time away from whatever your normal life is to go spend, half a day or several hours going to the doctor. And usually when there's a disruption in your routine, that costs you money because you can't do your normal thing that you're accustomed to. So in that scenario, this is where something like this can really help. Next slide, please. And then you have the ability to add on an outpatient surgical procedure as well. Basically, if someone were to go in for some type of day surgery, like maybe they need to get their shoulder scoped or their knee cleaned up, something along those lines, then those can get pretty costly. Well, you can once per year, if you add this rider on, and you can do it as high as $1,500 per occurrence or per usage, but you can only, again, use it once per calendar year, then that will reimburse them up to that amount for that type of procedure, which is a good benefit to have. And then you also have the ER visit or ambulance service, $200 flat fee or flat payout benefit, I should say. You can use it twice per year. And it's again, to help offset some of the blow that you're going to be faced with if you end up having to be in the ER or take an ambulance visit or ambulance ride, excuse me. And then you can add on a lump sum cancer, which this is sort of a newer feature with this newer version of the hospital indemnity. And this, again, if you've got someone out there who's a Medicare Advantage client, there's a lot of a gap, or a big gap, a large sizable gap there for someone who, gets diagnosed with cancer. So what you can do with this is you can tack it on, and it will pay them back $2,500 or $5,000 or $10,000, depending on how much you choose, for their first occurrence of cancer. So that's a great benefit to add on. And then another newer rider that you have is the outpatient rehab. This will pay a daily amount for treatment of a covered illness or injury. And this is a big thing too. When you end up in skilled nursing, you've got to usually go through rehab, or even if you're recovering at home, and those can get pretty costly. So it covers all 3 different types of therapies: occupational, physical, or speech, and it's available for either 15 or 30 visits per year, $50 per visit. So that's all the riders that we have. Period of care we discussed, it's 60 continuous days. Policy is guaranteed renewable. Benefits are paid directly to the policyholder. So just so everyone understands, this is going to be a check that's paid or sent to the client once they file their claim. And we turn these claims around pretty quickly, usually less than a week. So keep that in mind. Premiums don't increase due to age or health. But furthermore, they don't increase at all. We've built these products, not just the hospital indemnity, but actually all of our ancillary products. We've built them with the intention of never increasing the rates. We started getting into these products back in the mid-90s with our ancillary line of products. They've come a long way since then. During that time, we've never done a rate increase on any of them, and we never intend to. That's another important thing to consider when you're selling and marketing these products. When you lock in your premium, especially hopefully those at a younger age, then your premiums are never going to go up. Next slide, please. Again, it's a simplified underwritten product, yes or no app, no phone interview is required. You will do a prescription drug check just to make sure they don't have any kind of knockout drugs. Your pre-existing conditions will be covered after 3 months of the policy being enforced. Now, with that being said, keep in mind, it's got to be a pre-existing condition that doesn't knock them out from coverage from being able to buy the policy also. Everything else is going to be covered immediately. Your pre-existing after 3 months. Next slide, please. And again, I'm not going to go through the entire app, but I just wanted to throw it up here so you kind of get an idea of what it looks like. As you can see, it's all yes or no. Same scenario here. It's a one-page app. I couldn't fit the entire page on one slide, so the second half is on the next slide. And you can see there, it's just, very easy, underwritten. It asks about diabetes. And yes, you can write this for someone who has diabetes. You just got to make sure that it's not out of control diabetes. So that's one of the questions are a little specific there. So trying to move at a quick pace. I hope I'm not going too fast for you, but I don't want to get bogged down with details too much. We can always have offline conversations if anyone wants to take a deeper dive in any of these products later on with me. Just to review here, I'll just throw this up here for a minute. You've got your base options. One is going to be the lump sum, and then you have the daily payout if they choose that instead. And then your optional riders are daily skilled nursing, doctor visit, outpatient surgery, ambulance and ER, cancer diagnosis, and outpatient rehab. Hopefully that all makes sense to you. We'll go ahead and move on to the next product, which is our recovery care. I love recovery care. I'm so excited that we're getting it in Texas later this month, at the end of the month, actually. We haven't had it. By the way, in case I didn't mention, Texas is my home state, so I spend a lot of time there. So we actually don't have it everywhere, as you can see on this map. Texas is kind of the one big one that we're trying to get it in. If you look in the upper left-hand corner, it does say June 1st, but we pushed it back to the end of June, but it is going to be launching there. I think June 28th is the actual date. But everywhere else, you've got a big chunk of the map there that is green and good to go. And let's tell you about the product. Go ahead, next slide, please. So this is for people who are concerned about coverage for nursing care, or they don't have funds set aside for skilled stays or home health care. And that's the unique thing about this product is you can build it. It's a short-term care plan, and you can go ahead and flip to the next slide, but you can build it to be like a long-term care plan. And as you know, probably if you guys have looked into long-term care at all, it's very expensive, and most people have a hard time even qualifying for it. So this is a simplified issue product that isn't technically a long-term care product, but I'm going to show you how you could build it to be sort of, very similar to a long-term care product. So this is the base benefit. It's a daily nursing facility, including assisted living and bed reservation. It pays a daily benefit for confinement in nursing facility or assisted living, provided the policyholder cannot perform 2 or more of the activities of daily living or has cognitive impairment. So what that means is that's the trigger. In order to trigger the benefits, they've got to be able to not perform 2 or more of the ADLs or have cognitive impairment. You can max it out up to $300 daily, and you choose the number of covered days that you'd like to have. You can do 90, 180, 270, or 360. So 360 almost a year. Not to mention, whatever the number of days you've chosen, you can use it a maximum of 2 times. So if you were to choose 360 days, once you've used all those 360 days, that doesn't mean the policy is no good for you anymore. You can reset the benefit by not needing any care for 6 months. So there's a 6-month period of care in there. I know that may be a little tricky depending on the type of condition they have, but if it really is more of a short-term recovery where they need a lot of recovery over a long period of time, but it's not going to be more than 360 days, then you can re-trigger the benefit. You know, if the recovery is actually going to get them better long term. The waiting period, you can do either 0, 20, or 100 days. I recommend 0 days. The issue ages on this product are 50 to 89. So while it's not as low as some of the others, still you can start writing people right around age 50 now, which is when they're starting to get concerned about these types of things. Next slide, please. Okay, the other base benefit on this is that it's got a hospital. If you go back one, I think we went ahead to. We've got the hospital indemnity also built into this. So you could have up to $300 daily for 20 days of care at a time in the hospital, and you can use that a total of 365 days. The reason that this is in here is because this is how we built the product. We built it on the chassis of a hospital indemnity. If you really didn't want to build a lot of hospital coverage in there, you don't have to. You do have to put the minimum though, which is just $10 daily. So just keep that in mind. Next slide, please. You do have an optional home care rider. This is where you can really build this into being more of a long-term care product. It pays for each week the beneficiary receives 3 or more professional home care service visits of at least 1 hour per visit, provided the beneficiary cannot perform 2 or more of the activities of daily living, or if they have cognitive impairment. So the triggers are the same as the skilled nursing benefit. You can max it out at $1,200 weekly maximum, and you can choose the number of weeks at 13, 26, or 52. So if you put the skilled nursing at 360 days and put the home care at 52 days, you really have a 2-year long-term almost type care plan. So keep that in mind. And the same way this works as the skilled nursing benefit, you can use your total number of weeks twice. You just have to go through that period of 6 months with no care. Next slide, please. And we already talked about the period of care. Policy, is guaranteed renewable. Benefits are paid directly to the policyholder, and the premiums do not increase at all, as we mentioned, on all of our ancillary products. Next slide, please. It is simplified underwritten, yes or no application, no phone interview. You want to check prescription drugs because there could be some knockouts there. The policy will pay for pre-existing conditions once it's been enforced for 6 months. Benefits for all other covered injury or sickness begin the date the policy is issued. Next slide, please. And here's just a quick sneak peek at the app. This is the first half, and then the next half. And there you go, just all simple yes or no questions. And then here's just a review. Again, you've got a nursing. It's triggered by ADLs. You can do $300 daily maximum. Cover of days are 90, 180, 270, or 360. And then you've got the hospital indemnity at $300, and then the home care rider at $1,200 for 13, 26, or 52 weeks. And we're going to wrap up recovery care and go into Home Care Plus. This product works very similar to Home Care Plus. As you can see, we've got it in most states already. The cool thing about this is you can actually write it on someone who's been diagnosed with Alzheimer's or Parkinson's, or if they had cancer this is 1 year ago. So you really are a lot simpler underwriting on this one. Next slide, please. If anyone's concerned about funds not being set aside for home health care, this is what this product does. Next slide. You can skip past this one, actually. So the base benefit is going to be, it's going to be for home care, and it's for coverage will pay, sorry, 1 second, I got an alert popping up on my screen. The coverage will pay a weekly benefit for in-home care by a home care practitioner or qualified staff member of a licensed home health care agency. Home care services must be medically necessary. So the trigger is different than recovery care. The trigger is just the doctor's got to initialize it. They've got to basically write a prescription for it, or they have to, write a letter saying that this patient needs this. You need 3 practitioner visits per week, and it's up to $1,200 weekly. Choice of covered weeks are 13, 26, 39, or 52. You can use the total number of weeks twice. You have a waiting period of 0 or 20 days. I recommend 0. Issue ages are 50 to 89. Next slide, please. You've got that same hospital indemnity built into this, $300 daily if you like, 20-day period of care, just like the last one. Next slide, please. And you've got 2 optional riders that you can add on. You can do the lump sum cancer, which is the same as the hospital indemnity flex. It's either $2,500, $5,000, or $10,000. You can do ER visit and ambulance service, and that's $200 per occurrence, twice per year. Next slide. Period of care is the same as what we've been discussing. It's going to be 6 months. Policies guarantee renewable. Policy benefits are paid directly to the policyholder, and premiums do not increase. Next slide. It's simplified underwritten, just like the other products, yes or no app only. Pre-existing conditions will be covered after it's been enforced for 6 months. Benefits for everything else begin immediately. Next slide. And this one's really cool as far as the app goes. This is literally the entire app. So I didn't even have to break it up onto 2 separate pages. So like I said, this one's really easy to get issued. It's got much less underwriting than Recovery Care or any of the others. So I would encourage you, if you have someone that's a little bit, maybe they want to buy something, they want to get some coverage, look at this product. And then there's just a review. We'll go ahead and skip. I'm trying to hurry up because I don't want to put you guys on for too long. We've got one more product to cover, and we'll just go through it real quick. This is our dental, vision, and hearing. It's really new, so we haven't launched it everywhere yet, but it should be in all the normal states very soon. This is where it's at now. Go ahead, next slide. So my big thing on this is it covers things that Medicare doesn't, and it does it for less than $50 a month. The coverage can be for individuals or families. Issue ages are 0 to 89. Unlike our cancer, heart, stroke plan, the eldest applicant must be the primary. It is guaranteed acceptance. It's a guaranteed issue product. Nobody, can be declined for it. So there's no health questions. It will cover dental, vision, and hearing expenses. It's going to be either a $1,000 base plan or a $1,500 you choose. You have a $100 deductible annually for every person that's included on the policy. You can go to any provider, but you're going to get much, much better pricing if you go in network, which our dental network is going to be Carrington. And they're very good. They're great at being able to make sure you get really good discounts on all your services. Next slide, please. So for dental, we have 3 different classifications of service. We've got basic, and then we have intermediate, and then class C, which is going to be more advanced, like dentures and things like that. And then we'll go to the next slide, and I'll show you what the waiting periods are on each. So class A and B are going to be covered immediately for each visit or for each procedure, however you want to look at it. It will pay 60%. That's in year 1. In year 2, it actually increases to 70%. And then in year 3, it's 80%. So it goes above and beyond. It gets better after the first couple of years. That will cover diagnostic exams and x-rays, non-surgical extractions, and emergency palliative treatment. Now, after 12 months, then they can start using their Class C services. That will pay 60%. That will include endodontics, including root canals, periodontal surgery, bridges, crowns, and full or partial dentures. Next slide, please. Vision, I'll just throw this up here. Basically, the way it works, it starts, the coverage kicks in after 6 months, and it will cover basically for you to get new glasses and or contacts every 2 years, which is on average what most people are getting who wear glasses or contacts. And then we'll flip to the next slide, which is going to be for the hearing. Hearing, it will be in effect after 12 months. They can use the hearing benefits. It's 70% in year 2 and then 80% in the 3rd year, and it stays at 80% after that. And it will basically apply $500 annually from that point going forward, either to hearing exams and or hearing aids. So some additional benefit there. Next slide. So just to wrap a few things up here, we're here to help you guys. Our email address is going to be I'm trying to say 2 different things at once. The email address is aetssiinformation@aetna.com, and we're actually really good at responding to emails. Website is going to be aetnaseniorproducts.com, and the phone number is 800-264-4000, option 3. That's our sales support team. So call them if you want to check anything or have any questions. And you can also call me. Next slide, please. And as promised, here's the contact information for all of our regional support sales teams. In the West, which is going to be my region, you have myself and my boss, Tony Clark. And then at the home office, we have William Davis on our team as well. And then for the Midwest, you've got George Pelicanos, David Friedman, and Rose Faulkner. In the Eastern states, Jeff Nasser, Paul Erickson, and Georgia Fletcher. So hopefully you got a minute there. You can jot down a phone number or email if you want to reach out to any of these folks. We'll go ahead and move on. I want to tell you guys about our incentive plans. I know we didn't cover our MedSup product today, but I want to let you know that we've got a sales contest going on or through the end of the year that's to help you make some extra cash. This is for our MedSup, and basically for underwritten MedSup policies, we're going to bonus you $100 per application for every underwritten policy. For open enrollment, it's going to be $25. Next slide, please. And then this is our brand new ancillary bonus program. We're going to bonus you $25 for a DVH sale, $25 for a cancer, heart, or stroke, $25 for a hospital indemnity, $50 for recovery care, and $50 for home care plus. And then if you pair any of those, except for the DVH, any of the others though, if you pair them with a MedSup, a new MedSup sale, we'll double your bonus money. So you can put, and by the way, the compensation in general on the ancillary products is really, really good. So making extra bonus money on it is pretty awesome. And then last but not least, next slide. I want to let you know we do an annual trip. We went to Miami for last year. We just went a couple months ago. The trips are awesome. We go all out. As an agent, you only need $200,000 in annualized premium, and we're going to bonus you on underwritten business. So if you write $80,000 in underwritten MedSup business, we'll give you a $30,000 credit towards that $200,000. And then if you write our e-app, if you use our e-app most of the time, we'll give you a $20,000 production credit as well. And then last but not least, the best thing and easiest way to qualify with is if you write our complementary products, like the ones we've talked about today, all of those count 3 for 1 towards trip qualification. So you only got to write about 65,000 in ancillary products, and that qualifies you for the trip. They're 3 for 1, so take advantage of that. I'd love to see you guys in Palm Springs next year. With that, I will say thank you, and I will turn it over to John to see if he has any questions for us.
And Kevin, we have one question, and you covered it, and the question is, does the premium ever increase? And you noted with the different products that it stays constant from the initial premium that was charged for the policy. So beyond that,
awesome.
We've got her covered. We're going to take just a couple of minutes to speak to a couple of things that Premier will do for you in conjunction with Aetna and their supplemental products and their MedSup products. So some nice things that are available to you. We do offer discounted E&O for agents that contract with our organization. We discount continuing education credits so you keep your license in place. We'll have a program that allows you to electronically contract with a number of programs as well. It's our response to carpal tunnel syndrome, where you only have to fill it out once, create a profile, and then pull and fill contracts out electronically. So it's a nice time saver. We do periodic educational opportunities of different webinars that are both recorded and live in many circumstances. They change each month, so watch for those and the invitations that come out to you. We do offer different electronic support as well. So as Kevin mentioned during his presentation, it's a lot easier once we get in the habit to do things electronically. The applications process more cleanly and more quickly, which means we get paid more quickly. So accessing electronic support is a very big advantage to agents with whatever products they have. And we have a specialized program for that for our Medicare Advantage, select Medicare Advantage and prescription drug programs as well. We do also offer an exclusive program for social media, so a way to help you prospect and keep in touch with your client base through Al Gore's wonderful wide world web, and a comprehensive lead program for you as well. Opportunities to present such programs as what Kevin mentioned today through community-based programs We work with a number of different retail marketing programs. We have specialized initiatives to work with faith-based organizations and providers in the community, and other ways of offering different lead support, including an innovative direct mail support program, which steeply discounts the cost of a mailing based on production. All said and done, it's an opportunity with different products to make certain that you serve your prospects and clients as thoroughly as possible, not only to cover all of the needs that they have, but also to create multiple income streams for you and your agency. And we would like to help you with that business. So the old story of when all is said and done, more is said than done. Well, you were presented a great portfolio of supplemental products today that I will guarantee just about everyone that you speak to needs one or another of them. And you can't really determine based on your own perception who needs what. And I'll throw in a very quick personal example. Cancer, heart attack, and stroke. I'm fighting cancer. And as I came out of the hospital, my older brother stayed with me when I wasn't allowed to be alone. I'm fighting it successfully, by the way. But I never thought I'd have cancer. You don't know. My brother stayed with me a period of time, went home, had a stroke within 2 months of going home. He never anticipated that either. And you really don't know what those extra expenses are going to be until you experience them. So if you don't have a cancer or heart attack or stroke policy, I urge you to get one. I urge you to also contract with that portfolio of products that Aetna offers so you can offer it to your prospects and clients as well, because it's something you need to incorporate into your own personal marketing plan. And once you do that, commit to yourself that you're going to actively market and follow through. This is contact information for folks here in our Dallas office. We'd be happy to help you in any way we can with the Aetna portfolio. If you are currently working with another marketing person within our organization, you can reach any of us through the 1-800-365-8208 toll-free number, and we'll be more than happy to get you all the information on the Aetna supplemental programs that were discussed today and the Medicare supplement programs as well. We want to thank you for coming on the line with us today and spending some time, and we wish you good selling. Thanks so very much, and have a great day.